Good morning and welcome to the final day of the Kyiv Summer Stroke Summit. We begin with special session 2, which will focus on key updates for stroke neurologists. We begin with a lecture by Professor Bo Norving from Sweden, Professor of Neurology at Lund University, founder of RIX Stroke, the world's first national stroke registry, and former president of the World Stroke Organization. With extensive contributions to global stroke policy and classification, who will discuss the transition from ICD-10 to ICD-11 in stroke practice, a topic particularly relevant for improving consistency in stroke classification and clinical communication.
So, welcome everybody. My name is Bo Norving. I'm senior professor at Lund University, and I have worked with stroke for several decades. I'm very happy to present to you at this Congress, and you have an extreme respect from the outer world, what you are doing in Ukraine. Despite the difficult circumstances, you have been able to connect internationally. You have been able to support the stroke services in your country very actively, and you have done this in a way that is fully admirable. So, what you have done, I think, is stunning. That despite these problems, you're one of the most active, one of the most prominent contributors, for instance, to the Stroke Action Plan for Europe. And despite difficulties in traveling, you have been able to participate in very many physical meetings. I think it's wonderful that you now arrange this Kyiv Summer Stroke Summit, and there are so many of us who are really happy to contribute to this. So I send you my warmest greeting here from Sweden, and I'm happy to speak for you on one of my favorite topics, which I hope you will like. Warm greetings from Sweden. So, welcome everybody. My name is Bo Norving. I'm senior professor at Lund University in Sweden, and I will speak to you today on ICD-10 versus ICD-11, what stroke neurologists should know. So, first slide. The ICD-10 revision into ICD-11 was started in 2009, and in the history of the ICD classification at WHO, ICD-10 was completed in 1990, and then it was the longest interval ever before it was a revision, and it was felt that it was to be a major revision. It took much longer time than initially recognized. ICD-11 was approved in 2019 and is official ICD now since January 22. So if we're looking back on cerebrovascular diseases in the ICD-10, we see the following classification. The stroke is classified under diseases of the circulatory system. Transient ischemic attacks is classified under diseases of the nervous system. Silent cerebrovascular disease under incidental imaging findings. So this is of course inconsistent, it's outdated, and also a problem with ICD-10 was there were no definition in this version of it. So I was given the task to share the cerebrovascular disease group at WHO for the ICD-11 work. So I started with this in 2009, and we were in a very actively working group. And very soon, under the process, we found out that this is very logical. How shall we proceed with this work when is this division between different parties under different headings, who each of them had their own group? So the proposal that I made was that all diagnostic codes related to cerebrovascular disease should be in one block and under diseases of the nervous system. So we started to make connections to the other groups that were working with the classification, and there was initially a full acceptance and even by the WHO, and on the draft of the ICD-11 it was placed under diseases of the nervous system. But then in a very late phase of the work, the statistician at WHO decided that no, it should be the same, we should not change anything, so they changed back, and we had an intense period during about 1 year with a lot of debate, with a lot of arguments. So finally, it was success in 2017 that the decision was taken. And you can read at the bottom here the argument that was the most crucial one. Decision in 1955 to move the cerebrovascular diseases out of the chapter diseases of the nervous system created a disruption in the organ-specific location of multifactorial conditions. So we tried, I think, 20, 30, 40 different arguments, but this was the argument that was finally accepted, that an error was made in 1955, and now we are moving back and correcting. So the person who was responsible for the nervous system classification was a Raj Shakir, later on president of the World Federation of Neurology, and I got into this task in my role as president of the World Stroke Organization. So at the time when it was success, when we had been successful in classifying stroke under diseases of the nervous system, we took this photograph, and you can see that we are very happy. And we also wrote an article in the Lancet about this landmark, really, that now this was the case. So let's move now to what is the classification now in ICD-11 and what are the differences. And as said, it's now a single block of cerebrovascular diseases. It's placed under diseases of the nervous system. The block includes TIA, stroke, and cerebrovascular diseases not causing acute neurological dysfunction, and that is silent cerebral infarcts, cerebral microbleeds. And now also ICD-11 includes definitions of all diagnostic codes, including a definition of stroke. So this is now the global definition of stroke for the very, very first time. You know, there has been some discussion on different definitions of stroke for many years. And this change for stroke for cerebrovascular diseases in the ICD-11 was one of the most profound changes actually in the new classification. So let's take a look now. How does it look if you go to the web page at WHO and you can search for ICD-11, and it's a browser. Here you see it's use ICD-11, ICD-11 browser. And if you click here, you find the different diseases classified. So this is what it looks on the website. What you see here to the left is different categories of diseases. It's not the full list, but you can see that you have infections, you have neoplasm, you have diseases of blood-forming organs, etc. You have mental, behavioral, and neurodevelopmental disorders, and here you have diseases of the nervous system. And when you click up diseases of the nervous system, you have the subheadings, and one of these is cerebrovascular disease, and with the different entities that come below. So this is what it looks like, and what you can read here on this very important first slide is this is a group of brain dysfunction related to diseases of blood vessels supplying the brain. This includes the following entities which are labeled stroke: intracerebral hemorrhage, subarachnoid hemorrhage, cerebral ischemic stroke, and stroke not known as ischemic or hemorrhagic. This is the definition of stroke at present. So in ICD-11, then we have this classification, this clarification that what is a stroke? Is cerebral ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and stroke not known if ischemic or hemorrhagic. These are the four main types of stroke, what is included in the definition. And we will come back to this many times during this talk, that one claim, one need, one requirement to label it a stroke is that it has acute neurological dysfunction. So at the bottom you see then what is not a stroke. TIA is not included, non-traumatic subdural hemorrhage and non-traumatic epidural hemorrhage. It's not also classified as a stroke. Silent cerebral infarcts, silent cerebral microbleeds, not a stroke. And importantly, traumatic intracerebral hemorrhage, traumatic subarachnoid hemorrhage, everything traumatic is not included in the definition of stroke. So I will speak to you about some of these categories of cerebrovascular diseases. These are the headings that you see in the ICD-11: cerebral ischemic stroke, transient ischemic attack, intracerebral hemorrhage, subarachnoid hemorrhage, stroke not known if ischemic or hemorrhagic, other non-traumatic intracranial bleed, asymptomatic stenosis or occlusion of intracranial and extracranial artery, cerebrovascular diseases with no acute cerebral symptom, other specified cerebrovascular disease, and these two entities, and finally, late effects of cerebrovascular disease. So I will not speak on all of these items, but I selected 6 of them for more detailed explanations and clarifications. So in the upper right, you can also see 2 entities which are not part of cerebrovascular disease. And one of these is spinal cord vascular disease. It is vascular disease of the nervous system, but it requires that for stroke that it is localized in the brain. So spinal cord infarct is not part of stroke. And the same is with retinal infarction. In some clinical trials, retinal infarction have been part of the endpoints and have been joined as a stroke endpoint. Retinal infarction, it is in the eye and it's not part of the definition of stroke. So first, cerebral ischemic stroke in ICD-11, and you can note that the term now is cerebral ischemic stroke. The earlier terminology for this in the ICD-10 was cerebral infarct. And the definition is acute focal neurological dysfunction caused by focal infarction at single or multiple sites of the brain. Evidence of acute infarction may come either from symptom duration lasting more than 24 hours or neuroimaging or other technique in the clinically relevant area of the brain. So first requirement is that hemorrhage is excluded by an imaging technique, and after that it can be symptoms lasting more than 24 hours, or it can be neuroimaging demonstrated and infarct irrespective of the timing of the event. So some further things here about the classification here, and when we classified in the ICD systems, we have 3 hierarchical levels, and the first is the manifestation, the second is the location, and the third is pathology or pathophysiology. So when possible, the ICD asked for a classification according to pathology. And looking back in the ICD-10, the term is by pathology cerebral infarct, and it denotes a tissue injury from cerebral ischemia. And at that time of the ICD-10, cerebral infarct was thought to be equivalent to acute stroke. And we now know that 95% or more of all cerebral infarcts do not present as stroke. Silent cerebral infarcts is very common in the population. It's 20 times more common than infarcts that are causing acute neurological dysfunction. So there is a need in the ICD system to have a continuity of the different diagnoses. That what was one diagnosis in ICD-10, ICD-9, ICD-8 or so, and what has changed, what is happening now with this code in ICD-11. It's a requirement to track changes in diagnostic code between the different ICDs. So in ICD-11 now, ischemic stroke caused by tissue injury is the continuity to the ICD-10. And here you have some more details now on ischemic stroke. The diagnostic code acute ischemic stroke is without a time limit for clinical symptoms if tissue injury is demonstrated. And this is similar, for instance, if you have patients with a concussion and you do imaging and find that there is a tissue damage, then it qualifies for diagnosis of contusion. So ICD-11 does not define the method by which tissue injury should be diagnosed, but in principle, the most sensitive technique is, of course, MRI with diffusion-weighted imaging. If tissue injury is not demonstrated, and there could be imaging negative ischemic stroke, which is seen in about 15% of all acute ischemic strokes, symptom duration more than 24 hours is accepted as a likely fact that there is most likely some degree of tissue loss and hence qualified for a diagnosis of ischemic stroke. So now if we look at transient ischemic attack, you see the definition here that transient episode of focal neurological dysfunction caused by focal brain or retinal ischemia without acute infarction, again, without acute infarction in the clinically relevant area of the brain. Symptoms should resolve completely within the 24 hours. So we have the 24-hour limits for TIA, and this time limit is reciprocal to the time limit for cerebral ischemic stroke. So in TIA, we have transient ischemic attacks of the brain, and we also have amyloidosis fugax, or transient monocular blindness. Actually, this is not logical because symptoms should be classified in the end organ where it occurs. Amyloidosis fugax, it occurs in the eye, but under the discussion, decision was taken to group amyloidosis fugax together with TIAs of the brain. So TIA in the ICD-11 in patients with presumed ischemic symptoms lasting less than 24 hours. If imaging reveals no tissue injury, then you should code as TIA. If imaging is not done, code as TIA. Tissue injury needs to be proven visualized for diagnosis of an acute ischemic stroke. And the classification definition should not per se influence clinical practice. If CT scan or MRI should be performed or not is simply a diagnostic description. So, of course, there are now several issues with the new tissue-based definition. We have comparability of the epidemiological data for TIA and stroke that will be slightly changed, and we will look in further detail on this. And of course, the method of demonstrating acute tissue injury, even by MRI, is technique related and technique dependent. We have the problem of the sensitivity and specificity with the type of different MRI scanners. We have the timing of the examination. We know that in some patients there is reversibility of diffusion-weighted MRI findings resolving lesions. And also you need to analyze or examine if the imaged lesion is related to the clinical symptoms. And we know in clinical practice there is a wide variation in the use of MRI between countries and region, and we will see the effect of this. And also looking back, of course, we have a large existing literature on TIA using the time-based definition of diagnostic tools and finding, prognosis scores, therapies. So there will need to be new studies with a new definition, and there has been a number of such studies, which I will show you now. So what is the effect of changing the definition to a tissue-based definition? Here you see to the left, you have the column with TIA, with mild stroke, and the stroke of the other higher severities. I'm sorry, I go back to this one. And what happens with the tissue-based definition? Well, there will be a proportion of patients with a TIA found to have a tissue damage, and that will increase this column here with mild ischemic stroke. So the first study on this was by Obviagele and co-workers 2003, which found that there would be a decrease in the number of TIAs by 1/3 and an increase of the number of ischemic stroke by about 7%. This was the first study on this. And then we have seen several other studies. This is a Geneva stroke study based on the Swiss stroke registry. They have a very high proportion of patients examined by MRI, and you can see that by the use of ICD-11, the incidence of, sorry, I'm going back again, incidence of ischemic stroke was 107 according to ICD-11 compared to 90.4 in the ICD-10. So this is increased here by 18.3% with a high use of MRI. And they found that patients with ischemic stroke identified with ICD-11 but not under ICD-10 were younger and presented with lower MRI NIH scores. We have this publication, which is a systematic review of 25 studies, and you see the rate of scan positivity here was 24%, but with high heterogeneity. The scan positive rate when examining only studies that had low risk of bias was substantially lower at 30%, and you can see that ICD-11 would result in an increased stroke incidence between 4.8 to 10.5 per 100,000 persons per year, so about 5 to 10% according to this study. And this is the most recent study from UK, 672 patients and examined in detail. And you can see here that the incidence increased by 6.8% in the ICD-11 compared to ICD-10. And again, the finding was made, that these patients were younger, were predominantly male, had milder stroke with lower NIH score here. So this is the general findings. So we see in summary that yes, there is some changes, smaller, modest changes in the epidemiology of stroke. There will be some increase here in the proportion in the number of mild ischemic stroke with a tissue-based definition. So one possibility that can be used to compare ICD-10 to ICD-11, and this is something that is discussed now in stroke registers, is that you can have an additional code for these patients who moved from TIAs to acute ischemic stroke. You can have an extension code that acute ischemic stroke with remission of symptoms within 24 hours. If you code like this, you can have full comparability with the older and with the new classification. We are discussing this now, for instance, for the Swedish stroke registry. It has been discussed here with the WHO. Should we have this additional code? And WHO has said that, no, we don't think this is needed for a larger purpose. Internationally, globally, this is a very small detail. We will not do this. So for cerebral ischemic stroke, then we have the subdivision by subtypes, which you see here, and very much similar to the TOAST classification. So we can open up two of these just to look in more detail. Cerebral ischemic stroke first, due to embolic occlusion, and here you see the list of different items here, and all of such list in the ICD-11 is stopping with ending with due to other specified or due to unspecified. This is at the end of almost everything in ICD. If we look at cerebral ischemic stroke due to other known cause, then you see here other items that you can classify with this diagnostic code in the ICD-11. So what is most important in clinical practice and research? Well, it's absolutely that to ensure that the main type of stroke is correct before digging into the subtypes. That is correct if it is a cerebral ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and so forth, and miscoding of stroke, not stroke, is not there. Traumatic ICH and subarachnoid hemorrhage are often miscoded as stroke. So a few slides on intracerebral hemorrhage here, and here you can see that ICH is subclassified by location and not by the pathophysiology, but you can combine this with co-coding, and I will show you this on the second slide here. And first, an important distinction that stroke and not stroke. What is stroke here when it comes to intracerebral hemorrhage? We have the important terms of spontaneous intracerebral hemorrhage, which is defined as a stroke. And then we have traumatic intracerebral hemorrhage, which is not defined as a stroke. So this is a dichotomy, spontaneous versus traumatic intracerebral hemorrhage. And one important point here to point out is that it is spontaneous intracerebral hemorrhage, even if there is an underlying cause in the brain, for instance, a macrovascular or microvascular cause, or happened during oral anticoagulant therapy. So spontaneous is in opposition to traumatic ICH. And cerebrovascular diseases now with no acute cerebral symptoms. This is new in the ICD-11 that is placed under diseases of the nervous system and cerebrovascular diseases. And here we have silent cerebral infarcts, silent cerebral microbleed, silent white matter abnormalities associated with vascular disease. So there was a long discussion at WHO that should this be classified as disease or not, and this was a conclusion made, but it was very important to stress that silent cerebral infarct, silent cerebral microbleed is not part of the definition of stroke. So cerebrovascular disease with no acute cerebral symptoms, the definition is silent cerebral infarct not associated with acute neurological dysfunction, but we know that silent cerebral infarcts can be associated with effects of cognition, with gait disorders and more, but the distinction here is that it's not associated with acute neurological dysfunction. There's been some debate if you should use the terminology covered or hidden instead of silent, and this considered in the discussion, but covered was not the preferred term, and it was said that an identified abnormality cannot be labeled as hidden. So you may use covered as a clinical concept, but the suitable language is not a suitable language as a coding entity. So cerebrovascular disease with no acute symptoms. Here you see the text in the browser as it looks. And then we have a chapter on certain specified cerebrovascular diseases. And this is a list of cerebrovascular entities that can have different clinical presentations. Sometimes it could be asymptomatic, it could be a finding. Sometimes it could present as a TIA, sometimes as acute ischemic stroke, sometimes as a hemorrhagic stroke. So what you use here is double coding, that you can code the clinical expression, and you can use double coding to identify if there is a specified cerebrovascular disease behind. So this is what you do, for instance, when there is a cerebral venous thrombosis that can give a TIA, that can give a cerebral infarction, it can give an intracerebral hemorrhage. You use double coding to identify this. And here is examples of double codings that can be relevant for intracerebral hemorrhage, that you can classify it with the cerebral cavernous malformation, arteriovenous malformation, and cavernous fistulas, for instance, that is possible to classify by double coding the underlying cause. So coming out of late effects of stroke, this is now defined in the ICD-11 that codes for acute stroke should be exclusively used for acute stroke and immediately related hospitalization episode with the upper limit of 1 month. In the ICD-10, this was up to 1 year, and this created problems if you're going to use administrative data to denote if it was a new acute stroke or not, because it could be a patient that came in after several months after an acute stroke, for instance, with a hip fracture or something else, and where it was also the stroke was part of the diagnostic code. You couldn't tell then by the coding if this was a new acute stroke or if it was the first index stroke. So now we put that to an end and say that it should be exclusively used for acute stroke and up to 1 month after the acute stroke, but not any longer. So finally, what do the stroke-related changes in ICD-11 mean for practice and research? ICD-11 was adopted by the World Health Assembly in 2019, and it came into effect on January 1st, 2022. So now this is the official classification at WHO. It's a single block under diseases of the nervous system. There are official ICD-11 WHO definition of stroke, which replaces older definitions and definitions from other sources. There is now one global definition for stroke. There is this new entity of cerebral ischemic stroke. Instead of the previous term cerebral infarct, is a tissue-based TIA definition. We see that there are difficulties in comparing old and new data on the epidemiology of TIA and ischemic stroke. Number of ischemic stroke will increase, probably in the order of 5 to 50%, depending on much imaging you use in the acute phase. So updated list of other causes of cerebrovascular diseases. They can be used with double coding. And now the classification includes silent cerebrovascular disease, so the block covers the full clinical spectrum of cerebrovascular diseases. What do you do in clinical practice? The ICD-11 is now being introduced in different countries. It has been started in about 60 to 70 countries in the world, which has around 200 countries. So this is an ongoing process with the translation of ICD-11 into your own language, and there will be a start date in your country when it will come into effect and in practice. In Sweden, it will come into effect in 2027 as is planned now, but is already in place in several countries in the world, and there will be this change gradually to ICD-11. When we are using definitions in research, it's appropriate to use the ICD-11 definitions and the terminology and the principles now, and not to use the older diagnostic systems. And finally, now, stroke is a brain disease in ICD-11. What does that mean? Well, it correctly signals that when it happens, a stroke, it happens in the brain. And this is, of course, extremely important for the concepts of brain health and awareness campaign. It would have been very difficult to speak of brain health without stroke being part of this, because stroke is the largest neurological disease, accounting for 40% of all neurological disorders, really. Now, stroke has its own statistical line. It reflects the position of stroke as one of the core NCDs possible to prevent and treatment, and now placement of stroke is settled once and for all in all different circumstances. As some of you may recall, it's been discussion, should stroke be under diseases of internal medicine, should be in vascular neurology, should it be under circulatory disorders, and now is once and for all placed under diseases of the nervous system and as a neurological disease. And of course, this is very important from statistical views, for policies, for strategies, for advocacy. So with this, I thank you so very much for your attention. I thank you for inviting me to this Stroke Summer Summit here in Kyiv, and I wish you all the best with the course. Thank you very much for your attention.
Our next next speaker is Professor Patrick Lydon from the United States, Professor of Physiology and Neuroscience and Neurology at the Zilka Neurogenetic Institute at the Keck School of Medicine at the University of Southern California, and co-developer and leading advocate of NIHSS, who will present on new approaches to NIHSS training and certification.
Hello, my name is Patrick Lydon. I'm a vascular neurologist here in Los Angeles, California. I am very and deeply honored to be asked to participate in this summit. It is my pleasure to try to assist in any way that I can to the Ukrainian Stroke Association. And my topic today will be the NIH stroke scale. So I will first review a little bit about the stroke scale history and then finish up with a very exciting new version of the stroke scale that is animated. Everything that I'm about to say about how to use the stroke scale is contained in this paper from 2017. And in it, I present the history of the stroke scale, plus all of the tips on using it that I'm about to give you. So a little bit of history about the design of the stroke scale. An early version was created called the Cincinnati Stroke Scale. And the Cincinnati Stroke Scale was adapted for use in the NINDS TPA trial. And you know that trial because you use TPA for acute ischemic stroke. But what most people don't understand is that the NIH stroke scale was created for the purpose of assessing groups of patients, not individuals. So it's considered unreliable or a little imperfect for measuring a single patient. And that's true. It was designed for research and for assessing groups of patients, not individuals. Now, today, it was refined in a study called the naloxone study, and then it was used in the pilot studies of tissue plasminogen activator, and we did a validation study of it in 1994. So there's a few scoring rules that we use for using the stroke scale at the bedside. The most important rule is score what you see, not what you know. So when you look at the patient, don't overinterpret the patient's history and let that influence your scoring. Just score what the patient does, not what you think they should do based on your knowledge as a good neurologist. For most of the items, you want to score the first response, not the best response. So in item 1B, when you're asking the patient for their age, if they say, I'm 87, oh no, wait a minute, I'm 85. That first answer was wrong. That's the score. That's what you use to create the score. Now, if the patient doesn't respond at all, then we might have an arbitrary definition for their score. And I'll go through those with especially the sensory item, the visual item, and extinction. A quick look at the clinometric properties of the stroke scale. If you do a factor analysis on a large number of cases, the stroke scale breaks into two factors, and it turns out left brain and right brain. This was how the stroke scale was designed, but it's very interesting that the factor analysis after the fact works. This is the right explanation of the factors contained. And then each of those factors, the left and right brain, breaks down into a cortical component and a motor component. both on the left and on the right. So this speaks to the internal validity of the stroke scale. Now, this is the correct form. You can download this form from the paper that I mentioned. I attached this as a PDF to the paper, so you can download the actual form. And let's just go through the items real quickly. Item 1A is scoring the patient's level of consciousness. You just ask them how they're doing. How are you doing today? I'm doing great. That's a 0. 1B is 2 questions, and always ask them the same questions. What month is it? How old are you? And then 1C is 2 commands: close your eyes and grip my fingers. Item 2 is best gaze, and we only study horizontal gaze. Have you ever wondered why? You're a good neurologist, you know to test vertical gaze. In the stroke scale, we only test horizontal gaze. Why is that? Because the NIHSS was designed for research, and in a research environment, the stroke scale might be administered by a nurse, by an ED physician, by a technician. And they are not going to be as skilled as you are at assessing vertical gaze. So we only use horizontal gaze. Partial gaze palsy is scored as a 1. Everything else is scored as a 2. Visual confrontation is done with finger counting. How many fingers do you see? 1 eye at a time, 1, 2, or 5. We only use 1, 2, or 5. We never use 3 or 4. And a 1 is a patient with a partial hemianopsia, and a 2 is a complete hemianopsia. The only time you would use a 3 is if the patient has a stroke in both hemispheres and is presenting with bilateral hemianopsia, so-called cortical blindness. Moving on to the rest of the scale, the face question is very difficult for people to score. The face question can be made very easy. Just ask yourself, are they normal? Are they normal? That's a 0. If they're not normal, is there a complete paralysis of the lower face, the so-called upper motor neuron face weakness? That's a 2. Everything else is a 1. So it's only 0 normal, 2 for upper motor neuron, everything else is a 1. In the extremely rare stroke patient with a lower motor neuron facial weakness, that's when you use the 3, but that's very rare. Now, the motor item tends to be the best. This is the most reproducible item. But what I want you to do is always remember, you pick up the patient's arm. You pick it up and you drop it. And as soon as you let go, you start counting. 1, 2, 3. Don't tell the patient what you're going to do. Don't position the arm, let go, and then keep talking. I'm going to measure your stroke weakness now. Just pick it up, tell the patient, keep it up, and as you let go, start counting. Keep it up for 10 seconds. 1, 2, and so on. If it hits the bed, it's if it drifts but doesn't hit the bed, it's a 1. If it hits the bed, it's a 2. If there's no effort at all, it's a 4. But if they can shrug their shoulder, that's a 3. Leg item works exactly the same way. Pick it up and drop it. Start counting when you let go. Don't tell them what you're going to do, but you only count for 5 seconds. Limb ataxia is also a very difficult question. It's very difficult to get this right. You do the traditional finger, nose, finger test and the heel shin test. If there's ataxia in one limb, that's a 1. If there's ataxia in 2 limbs, that's a 2. Your job is to decide if the ataxia is out of proportion to the weakness. And even for the best neurologist, that's always a difficult decision. Now, the sensory question gets people a little bit confused, but it's actually very easy. Take a pin. Don't use anything else. Don't use a paper clip. Don't use a pencil. Use a pin, a sharp safety pin, and start touching on the right and the left and go back and forth, right, left, right, left. And as you're going back and forth, you say, which side feels sharper to you? Which side feels sharper to you? Or are they the same? Do the face, the arm, and the leg. Now, it's very easy to score. It's either normal, score is 0, or they don't feel you at all, score a 2. Everything else is a 1, okay? You don't have to worry about this one. It's very simple. It's either normal or a 2 means they can't feel at all. Everything else is a 1. Now, language is tested throughout the entire time that you're speaking to the patient. And you want to assess them for a mild aphasia or a severe aphasia, which is a typical Wernicke's pattern or a typical Broca's pattern. Or if they don't speak at all, that's a 3. So the 3 is easy. They don't speak at all. The 0 is easy. They're normal. But differentiating a 1 from a 2 can be tricky. So you may know what they have after you finish talking to them. You don't have to use the tools, but the tools are there if you want to. You can use the picture, ask them to describe it, and just listen to the fluency and the word choice, listen for paraphasic errors. You can give them the naming card, and if you think they're a 1, you should always give them the naming card because they might turn out to be a 2. So always use the pictures. And then you can have them read a sentence. There are sentences translated into your language, and they are available online. These are the English sentences. And you can use those if you're still not sure, but you're not required to use them. Finally, we come to dysarthria. And again, dysarthria can be difficult. It can be a difficult question. But just boil it down and make it real simple. If they're normal, they're normal. That's a 0. If the speech is so severe that you just can't understand anything, that's a 2. Everything else is a 1. Don't worry about this question. Is it severe or is it normal? Everything else is a 1. Extinction and neglect, item 11. You're really going to use the double simultaneous stimulation test, and you're going to do it twice. You're going to touch them with your fingers on the right, left, or both and see if they extinguish on one side. Then you're going to move your hands in their visual field, right, left, or both, and see if they extinguish. If the patient says right when you touch the right, left when you touch the left, and when you touch both, they say right, they're extinguishing the left side. That's a cortical sensory deficit on their left cortex. You can use other tests of visual neglect or tactile neglect. You can use anosognosia or agnosia tests if you want to, but the double simultaneous stimulation test is easy. You can do it quickly in a busy emergency department, and it gives you the answer. They extinguish for one modality, that's a 1. They extinguish on 2 modalities, that's a 2. These are the words that you can use to test for dysarthria. If you think they're a 0, but you're not sure, these are the English words. There are words available in your language that stress the ways of making speech. Now, if the patient is in a coma, you can try to score each item if you want to. You can go through the whole stroke scale, do your best, and score what you see. Or you can use these default scores. These default scores are printed in the paper that I gave you at the beginning of the talk in a table. And they're predefined. So if the patient does not respond at all on item 1A and they're in a coma, then you can pre-select all of these choices for each item on the stroke scale, and this will save you some time. So to summarize the first half of the talk, score what you see, not what you know. So let's take the example of the extinction question. Let's pretend that the patient is blind in one eye, okay? You're going to do the extinction test, and when you do both, they're going to extinguish on the side of the blind eye because of the blindness. Now, you know, as a good neurologist, that's not cortical, that's a visual. But you score what you see, not what you know. One for extinction, they say, right, example of score what you think. You should look at the instruction that I put and I keep that off. The questions use the first response, not the. And it is valid, it's useful, but we can do better. There is a better scale. This is how we made the original scene. If you've seen, and we did video in by collecting patients, bringing them to the studio, and having an examiner. Used two cameras, one camera to show you what the examiner is doing and one camera to show the patient's response. So you can see in the picture, the examiner is testing visual fields, but you can see the patient responding. This was state of the art in 2000, but the limitation is we can only show you what the patient does because we can only video patients in real time. Whatever patients we have available in the hospital, that's the only patients we can show you. It would be nice if we could to show you every possible response on every question. If we had 1,000 patients, we could video a mild face weakness, a severe face weakness, a normal face. But obviously that's not practical. This is another criticism of the legacy. There are 5 patients in test 1 and 6 patients in test 2, and you can see that the different items have more than one right answer. This is a side effect of the limitations of the video, that if you can't quite see the correct score, I have to score you correct if you have a slightly wrong answer. So this was a problem that we solved by allowing more than one right answer. Well, the NIHSS Plus is an app that you can download. It's at nihss.plus.plus. And you can download this app. And what it is it's an animated version of the training and testing. We validated this new app in a paper where we looked at a sample 1 of 42 nurses and doctors looking at 6 patients. In our second sample, after we improved the app, we tested 365 raters who each looked at 3 patients. If you've certified before, you know that we require you to pass 6 patients. We found in this paper that we actually only need 3 patients. So if you certify on NIHS Plus, you only need to pass 3 patients. This is how we animated the cases that you see. We put an actor in a motion capture suit, and then the person acts out the stroke scale, both the examiner and the patient. The actors wear the motion capture suit. And then we have facial capture software that captures the face. These videos, both the facial capture video and the motion video, are put into the computer, and we use a game engine called Unity. This is the same game engine that does these action games that you can play. And then we assemble the videos into an app that will run on the Android or on the iPhone, and it now runs on a desktop computer as well. The kappa statistic is a measurement of rater agreement. So we compared the kappas from the first tape that had 5 patients, the second tape that had 6 patients, and then there were some videos made later on DVD, sample A, sample B, sample C. You can see the kappas are pretty good, above 0.5. But the kappas for the app are much improved. The kappas are above 0.75. So the app has a significantly better inter-rater level of agreement, which is why we can get away with certifying on 3 patients instead of 6 patients. The app is mobile, and we can show all deficits. We can show every possible degree of face weakness, every possible degree of arm weakness, every possible degree of neglect. So the critical advantage are that all choices are demonstrated. There's user controls. So you're watching the video and you can zoom in, you can zoom out, you can switch perspectives if you want to look at the patient from the right side or the left side, because it's all 3D in the computer, in the avatar. Training is built in, so you can jump around and you can say, how do I do that item 7? And you can jump over to the training on item 7. Now, it's true that you only have to pass 3 patients, but we did tighten the pass scoring because you can see so well, we no longer allow multiple right answers. So you do have to get the answers all correct. The app looks like this. This is what the interface looks like. You'll have different scores for each item. And let's just look at a patient. I hope the audio works. All right. Unfortunately, the audio is not working, but you can see the clarity of the patient's movements. This was item 1C, where the patient was asked to make a fist and to close her eyes. And you can see she makes the fist, but she never closed her eyes. This patient is being tested for dysarthria. Maybe I can fix the sound. Stand by with me for 1 second. Okay, not going to be able to fix the sound real easily. Again, but you can see the clarity of the facial recognition. And then this gentleman has an obvious face weakness, and we're testing his eye movements here. And you can see his eye movements really well. He doesn't go to the left. He goes to his right, but he doesn't go to the left. Now you can switch your view here. You can zoom in or zoom out at will. I can't demonstrate that, but you can see just how beautiful the rendering is, and it makes it much easier for you to understand what the patient's doing. So in the last couple minutes, I just want to update you. This picture obviously is very out of date. It shows a woman in a dress washing dishes in a time from the 1950s. This led to some bias in the picture, and that led us to create a new picture. So this new picture is a little bit less gender biased, and it shows an equal number of events happening in the picture. So your patient will describe some things in the upper left quadrant, lower left, upper right, lower right, and there's lots of obvious things for them to describe and some subtle things for them to describe. Each piece of this picture is called a content unit. And for example, the spider hanging from the thread, that's one content unit. The boy is a content unit, but the fact that he's falling is another content unit. And so we tabulated all of the content units that people identified when they looked at the picture in a validation study. And then we also compared that among older patients versus younger patients, males versus females, racial preferences, ethnicity, education levels. And here is a graph of content units looking at the left side of the page, the right side of the page, or both. You can see that the mouse rat was detected by almost 50 out of 50 patients. So most everybody saw the animal. Most everybody mentioned the car. Down here near the bottom, the fact that the car outside the window had a flat tire, that was only detected by a handful of patients. But you can see there's a very rich amount of content for the patients to detect. So the new picture is very, very useful. You can download it from this paper here and use it instead of the old picture. This paper also has new words and new pictures for the naming test for the aphasia battery. So I hope that this has been useful. I hope that you're able to look at the app and consider buying it. It's not free, so that might be a limitation. We're working on a way to get it to you through other means, but for now, if you can download it and pay for it. And I think you'll find it much more useful and much more fun to use. Again, I want to thank the organizers of the symposium for inviting me back this year. It's a very great honor to contribute to the education of such dedicated neurologists under such circumstances that you're going through. I'm very grateful for the time, for your time, and I'm grateful to be asked to be here. Thank you very much.
We now move to part 1 of plenary session 5, which will focus on modern approaches to stroke diagnosis and prevention. We begin with a lecture by Professor Andrew Demchuk from Canada, who will address stroke in patients with cancer.
Welcome again, everyone. I guess I'm the last lecture of day 2 of the Kyiv Stroke Summer Summit 2026. So I have a topic of stroke in patients with cancer. I'm going to actually keep this somewhat short because I'm the only thing between you and dinner this evening and a break from a very long day of lecturing. So this lecture will be a bit shorter than my last. It's a fairly straightforward topic. These are my conflicts, responsibilities, and disclosures. When we think about cancer and stroke, we first need to go back and think about the ischemic stroke etiological classification called TOAST, where we have essentially the cardioembolic stroke, the large artery atherostroke, the small vessel stroke, the unusual cause, and the cryptogenic cause. Cryptogenic, of course, has since evolved into something called embolic stroke of uncertain source, which is distinguished from cryptogenic because there's an expectation of an extensive workup. And in that workup, no clear cause is found. So ESUS is a more refined, I think, and better definition than cryptogenic. Cryptogenic historically would sometimes include incomplete investigation or more than one cause. But what we're really talking about here is a full workup where no cause was clearly identified. The standard workup for ischemic stroke is a brain CT or MRI, ECG, echo, cardiac monitoring for 24 hours, and imaging of both the extracranial and intracranial arteries. Typically, an embolic stroke of undetermined cause is not lacunar. There's no evidence of any symptomatic extracranial, intracranial atherosclerosis with more than 50% luminal stenosis and the area supplying the area of ischemia that fits with the symptoms. There are no major cardiac sources of embolus, which include paroxysmal atrial fibrillation, sustained AFib, intracardiac thrombus, prosthetic cardiac valve, atrial myxoma, mitral stenosis, recent MI, or ejection fraction below 30%, valvular vegetation, or infective endocarditis, and there's no other specific cause seen. Why am I talking about ESUS? Well, ESUS strokes have evolved over the last 10 years, and we've begun to realize that there are a number of what I call soft ESUS etiologies that are likely in play. And this has led to a consideration of all of these over time, whereby cryptogenic stroke used to be 40, 50% of the patients we see, and now is dropped to below 10% because we're performing a more detailed evaluation of these patients and identifying some of these other causes. One such cause that falls into ESUS is the so-called occult cancer cause or known cancer cause, where the cancer is directly attributing to the ESUS stroke and is the likely explanation for it. And cancer-associated coagulopathy, or cancer itself, is probably responsible for close to 10% of all the strokes we see. On an average week on the stroke service, where I will admit somewhere between 10 and 20 patients, I see at least one stroke that I can directly attribute to cancer-associated, cancer-related coagulopathy or cancer-associated thrombosis. So I've actually moved on from the 5 main TOAST criteria, and I've now considered cancer as a unique etiologic classification. I've also put PFO-related stroke in its own category, and I split out unusual cause into arteriopathic and non-arteriopathic. So what I'd like to do now is talk a little bit about cancer and its relationship to stroke. Cancer-associated thrombosis causes stroke due in large part to a hypercoagulable state that it generates. But there are other considerations, including cancer treatment-related stroke risk. This includes cancer therapy-related cardiomyopathies or other similar phenomenon where therapies such as erythropoietin or tamoxifen or some of the more aggressive chemotherapeutic agents like the TKIs and the VEGF inhibitors do increase a predisposition to stroke. Radiation therapy from cancer can also lead to atherosclerosis. This is often delayed, sometimes 10 or 20 years later. If you get radiation for head and neck cancer or thyroid cancer, we've seen patients develop severe atherosclerotic disease in their carotid arteries overall. Infective endocarditis can be a complication of cancer due to the impaired immune system. But then there's really the big one, which is essentially the hypercoagulable state. The reason this occurs is that tumor cells will release microvesicles into the blood. And these microvesicles have tissue factor and other receptors on them that predispose to the formation of thrombin, fibrin, red cell collection, and netosis. And that all leads to a hypercoagulable state. Mucin is also considered in play as its impact on platelets. There's also an inhibition of fibrinolytic activity through the PI1 and TFPI pathways, essentially all creating a milieu of hypercoagulability. Certain cancers are more susceptible to this. Respiratory cancers, prostate cancer, breast cancer, pancreas, colorectal are the main cancers associated with this phenomenon of a hypercoagulable state, in particular the adenocarcinomas. The reason it's different in different cancers is there's really different receptors that are activated specifically. This is no greater a problem than in the pancreatic cancers, where there can be a tremendous hypercoagulable state that kicks in because of the activation of the coagulation cascade in pancreatic cancer. This is less seen in colorectal and rarely seen in oral cancers. What is the classic clinical features of cancer-associated thrombosis? 3 territory diffusion-weighted acute infarcts. A Trousseau syndrome where you see multiple scattered infarcts in 3 different vascular territories, usually small infarcts, but sometimes large, and the presence of an elevated D-dimer. And this is important. A lot of centers do not routinely perform D-dimer testing and often miss this diagnosis. I'll order a D-dimer when I haven't found an obvious source by day 3. And if it's very elevated, my suspicion of cancer becomes very high. So what are D-dimer levels to be concerned about? Well, the normal D-dimer level is generally below 0.5 milligrams per liter. It's borderline up to 1 milligram per liter with an age-adjusted D-dimer cutoff recommended, which is basically age times 0.1 being normal. So for example, if you have an 80-year-old patient, a D-dimer level of 0.8 milligrams per liter is considered within normal limits. Once you get much above 1, 1.5, you do have to consider diagnoses such as DVT-PE. And then, of course, when it gets much above 4, there are conditions like DIC and others to consider. Typically, in cancer-associated thrombosis syndrome, the D-dimer is well above 2 and generally above 3. While in cryptogenic strokes, without active cancer, it's rarely above 2. So anything below 2 is a little uncertain, but anything creeping up above 2 really raises the suspicion of cancer overall. And sometimes cancer-related stroke can generate D-dimer levels as high as 90, which is extremely elevated. What other conditions elevate D-dimer substantially? As I mentioned before, DIC, acute aortic syndromes, DVT-PE, and cancer. Those are really the only conditions that can do this, including aortic dissections. Patients with active cancer and stroke are at very high risk for recurrence. In fact, this is the highest risk group for recurrence of any of the etiological causes of ischemic stroke. The presence of an elevated D-dimer and multi-territory infarcts was associated with a 40% recurrent stroke rate at 30 days. I repeat, 40% recurrent stroke rate at 30 days, which is exceptionally high. There is a correlation between the level of the D-dimer and the risk or prognosis of Trousseau syndrome. If the D-dimer is above 9, the event-free survival approaches 0 within a year and a half in patients. The cutoff in general for Trousseau syndrome is about 2, as I said before, but at above 9, you get a very high risk of mortality even within the first 90 days. So this is a very serious condition for patients. D-dimers above 10 in a similar study at 30 days were already associated with a 40% mortality within a month, which is remarkable. The recurrent stroke rates were about 20% at a month in this particular study with a D-dimer over 10. So the level of the D-dimer matters. We recently changed our lab result approach to this, and now are taking a measurement right up to I think at least 50, as it helps us to risk stratify our patients with this condition. There is a correlation between D-dimer levels and microembolic signals on transcranial Doppler, and we know microembolic signals are associated with increased risk. Microembolic signals were emboli detection was performed in cryptogenic stroke patients and in the first day from onset, and in 1 in 6, this was positive. And the two conditions that typically MESs were positive in cryptogenic stroke were patients that were later diagnosed with atrial fibrillation and in patients with cancer-related stroke. So the MES relationship there is significant, and there was a strong correlation between MES and D-dimer levels. The presence of MES in cancer is a poor prognostic sign, again, for both stroke and event-free survival within the first 90 days. So this is another tool in the armamentarium to assess patients where you're suspicious of cancer-associated thrombosis. Now, the main cause of stroke and cancer-associated thrombosis is intravascular coagulopathy, but in some cases you can also get non-bacterial thrombotic endocarditis on the valves, and of course can develop DVT with PFO-related stroke. The clues for these conditions are, of course, in the setting of a non-bacterial thrombotic endocarditis, it's the microembolic signals, the presence of a valve vegetation on TE, and the 3-territory sign on MRI. For paradoxical embolization, obviously looking for a PFO or identifying a DVT on venous ultrasound would suggest that that's part of the mechanism of action. And in one study of ESA strokes with cancer, the PFO was detected in about 20%. And in that group with PFO and cancer with ESA stroke, 45% had evidence of concurring VTE. So clearly the PFO DVT scenario is a factor in some of this cancer-associated thrombosis syndrome. So what's the best treatment for this? Well, we don't have really good head-to-head studies in secondary stroke prevention, but in comparison studies of enoxaparin with warfarin showed dramatic D-dimer reductions with low molecular heparin therapy. That was not the case with warfarin. And so it's possible that warfarin is insufficient in achieving any clear benefit. In randomized trials of venous thromboembolism from cancer, the DOACs of apixaban and rivaroxaban and edoxaban were associated with less VTE than low molecular heparin, but substantially more bleeding overall. So it's still unclear which of these therapies is best. The only randomized trial in secondary stroke prevention was comparing edoxaban with enoxaparin in only 40 patients. There was perhaps more reduction with enoxaparin and D-dimer levels, but overall not a big difference. Stroke recurrence rates were similar, but there was substantially more bleeding in patients with edoxaban overall. So for now, we still aren't sure what. Generally speaking, we use DOACs as frontline in these patients. Unless they have a GI cancer where the risk of bleeding is high, then we'll certainly use low molecular heparin. If the D-dimer is really, really high, I generally go straight to low molecular heparin and sometimes even consider BID dosing so that you don't have a niter in this very aggressive coagulopathy. So, of course, in some cases, we have patients with Trousseau's syndrome of elevated D-dimer and in some cases multi-territory infarcts, but there's no history of cancer. So, when is it appropriate for us to screen for cancer? Well, certainly in that setting, I would screen for cancer if the D-dimer was quite elevated, in particular if you had the three territory scattered infarcts. Other factors associated with active that might represent active cancer risk is a history of smoking or anemia in these undetermined etiology stroke patients. So the clues really are things like D-dimer, older age, anemia, and prior thromboembolism, where you might want to consider assessing patients further for cancer. In one study of cryptogenic ischemic stroke recently published, 170 cryptogenic strokes underwent the FDG PET-CT for occult cancer, where a total of 25 abnormal PET cancer studies were identified. So roughly 10 to 15% yield of cancer, which is not small. And most of these cancers were in the digestive system overall. The biggest predictor of a positive PET study looking for occult cancer was in the patients who had a persistently elevated D-dimer at day 15 post-stroke. The FDG PET study can also detect venous thromboembolism, so you may have the added benefit of finding the source of venous clotting, especially in that cancer patient with PFO and possible DVT. So please consider occult cancer and known cancer as a real significant cause and probably a unique etiology for ischemic stroke, and something that you must look for when you are contemplating ESUS as a possible category for your stroke patients. There are many clues in patients with ESUS that can help you identify some of these soft etiologies, and so I've kind of listed them there. But the one I'm focused on for this particular talk is cancer, and it's that D-dimer over 2, the persistent D-dimer elevation, the multi-territory small scattered infarcts, the active microembolic signals early from onset and otherwise cryptogenic stroke, where I think you have treatment options of both DOAC and low molecular weight heparin, which at least appears to be a safer option from a bleeding perspective. So again, thank you for your time. And again, I'd like to encourage you all to, if you're interested in developing advanced training in stroke, we would be interested in considering you for training. Please reach out to me, or please look at our website here, which describes our fellowship program and has all of our prior 125 alumni of trainees. Thank you for your attention.
The next lecture is by Professor Anish Singhal from the United States, who will discuss stroke in young adults.
Hello again. I'm Dr. Singhal. I'm back to give a short lecture on ischemic stroke in young adults. I hope you've been enjoying the lectures so far. And again, I'm very grateful to Dr. Yuri for inviting me. This is 2026. I hope that by 2027, there is peace and we can actually be with you physically for this important summit. So ischemic stroke in young adults is another important research area of mine, and I've been quite active. We formed a global alliance now, so I hope to see a lot of progress in the field of stroke in the young. As we approach this topic, I want you to pause and think. How frequent is stroke in young people, defined as age 18 adult until about age 55? Are the causes of stroke in the young different, or are they same as in the older patient? How should you approach the diagnosis? And lastly, what is the impact if you're young and still in the workforce or going to university, you have a stroke? I think the impact might be very different than someone who gets a stroke at age 75 or 80, right? So that is why stroke in the young is different, and we have to be very, I think, focused on their specific issues that we have to deal with. So worldwide, stroke in the young affects more than 2 million people. It's a lot. It accounts for 1 out of every 6 strokes. So it's actually 1/6 of the most important cause of disability in the world. So I think it's really, really important. And how common is it? Well, in a survey, a lot of patients reported having had a stroke, and the frequency may be twice that of a new diagnosis of multiple sclerosis, which we commonly associate as a disease of young individuals. So bottom line, it is extremely common. These are data from the NANES study showing the percentage of the population who had a stroke or TIA below the age of 50. So the incidence is slightly variable depending upon which study you look at. Seems to be more in the low socioeconomic status. In Europe, it's about 8 per 100,000 patient years, but in the less developed countries such as India and Africa, and also in the East, as in China, the frequency is much higher. This may be a bit of ascertainment bias as to what we define as a TIA and stroke. In the United States, this is the Greater Cincinnati Northern Kentucky Stroke Study. In the age range of 20 to 54, you can see here the incidence rates. They're quite different depending upon the race and ethnic subpopulation. Young stroke can also be fatal. In the Netherlands, the Future study has looked at this. The 30-day case fatality is 4.5%. So, 1 in 20 such patients would die. And they've also got the 1-year mortality, and later on I'll show you the 5-year mortality rates. It's quite impressive. There's a lot of disability as defined as the modified Rankin scale score more than 2 was observed in 1/3 of such patients. It is rather disturbing that multiple studies have now shown that the incidence of stroke in the young has increased over the past decade or 15 years. So these data show comparisons from the 1990s to the 2000s or 2010s. And you can see in almost every study from Denmark, France, Sweden, etc., the frequency appears to have increased by about 40%. We don't know why. We think it's because of untreated risk factors such as hypertension and diabetes. It's also possible that the diagnostic threshold has changed, previously based upon CT or pathology, and now based upon MRI, which is much more sensitive. However, digging deep, it does appear that the true incidence has also increased. It's possible that there's a rise in illicit drug use or contraceptive pills, autoimmune disorders, infections like COVID-19. So all of these may be driving a higher frequency of stroke in the young. But a lot of this, if this is from premature atherosclerosis, it has implications for the government to do more, for example, healthy diet and promote physical exercise, which can reduce the risk of stroke from any cause. Dr. Putala from Helsinki has done phenomenal work over the past 20 years. This is one of his older papers showing that if you classify the mechanism of stroke according to the standard TOAST criteria as large artery, small vessel, cardiac, undetermined, or other, you can see that there's a difference in the recurrent rates. This is the cumulative risk, which keeps rising, but it's the highest in large artery athero, even in young individuals. And here he looked at the number of traditional vascular risk factors. The more risk factors there are, the higher is the risk of a recurrent stroke in all subtypes, including other determined mechanisms such as vasculitis. So I think it's important to control risk factors regardless of what the cause of the stroke was. And again, that was recurrence, and this is mortality, as you can see. Look at the risk, it's all approaches 30%. in 5 years in patients with large artery atherosclerosis. So it's a big public health nuisance. So I can only summarize and really emphasize that traditional risk factors, which we think of in older individuals, blood pressure, diabetes, etc., they're common even in the young. And they have a heavy contribution to ischemic stroke, not just from premature athero, but maybe the combination of atherosclerosis with whatever the condition is. It contributes to stroke recurrence, mortality, and in my opinion, even though there are no specific trials looking at the effect of, say, an antihypertensive to prevent cardiovascular illness 10 years later, there will probably not be such a trial. It is important to extrapolate from adult trials and administer things like statins, antihypertensives, antiplatelets, and emphasize physiological strategies, even in young individuals as young as 18 years. The American Heart Association has come up with a nice little formula called Life's Essential 8, where they emphasize things like sleeping, diet, exercise, and then, of course, all the traditional things like treating blood pressure, diabetes, stopping cigarette smoking, for example. So following these basic principles of healthy living can significantly reduce the risk and disability from stroke. In the young, there are certain issues that are more specific to women. I'd like to emphasize that stroke risk is increased in women with early menopause. There's a twofold increased risk. In those using estrogen, and in those with migraine with aura. There have been at least 4 or 5 cohort studies showing that there's a persistent increase and consistent across all studies. It was migraine with aura, not migraine without aura, not tension or cluster headache, but migraine with aura carries a 2 to 3-fold increased risk. And in young women with migraine with aura, if they also smoke and also have oral contraceptive, the risk becomes nearly 9-fold higher than a woman who doesn't have any of these risk factors. Now, remember that the baseline risk is low. So a 2-fold increased risk is, if you take 0.1 and double it, it's still only 0.2. But a 9-fold higher risk is very important. So you must counsel young women not to use estrogens, to avoid smoking, and it is important to treat migraine, even though there's no data that treatment of migraine reduces the risk of further stroke, but it is logical to presume that it does. Women who are pregnant also have higher rates of pregnancy-related stroke, and an important paper in the New England Journal has shown that the risk of cerebrovascular and really thrombotic events persists until 6 weeks, and in some patients even until 12 weeks. So that's sort of the big risk period. These patients often have postpartum angiopathy, which is nothing but RCVS in the pregnant patient, and also postpartum preeclampsia, which are common reasons why they develop cerebrovascular complications. When you think about young stroke, we often don't think about stroke in the young. By that, what I mean is, if a young individual comes in with a new symptom, we think of multiple sclerosis or tumor or infection, but stroke doesn't come to the forebrain. As a result, there's frequently a delay in the diagnosis or misdiagnosis of acute stroke in young adults. This is a small study, but I don't think it really needs to be repeated because the story is out there now. They took a consecutive cohort of young stroke patients and found that 14% were misdiagnosed, especially if they were seen at non-primary stroke centers. If they were even younger than 35, there was a higher risk of misdiagnosis. And then posterior circulation strokes, because they came in with nausea, vomiting, and a bit of dizziness, and they were diagnosed with gastroenteritis, for example. That's an important miss, because a posterior circulation stroke is more often fatal. And if you attribute it to gastroenteritis and you miss a cerebellar infarct, that can be serious, because patients can have a fatal outcome. Early use of MRI improves diagnostic accuracy, obviously. And what these data emphasize is that there's an increasing need for young stroke awareness. Another important issue in the young is that they come in with all sorts of different syndromes, which may not make you think of stroke as the first thing. For example, acute neuropsychiatric manifestation. As you probably know, patients with top of the basilar medial thalamic stroke, their only manifestation can be acute psychiatric change, catatonia, or I've seen a patient with globus hystericus who proved to have a stroke. They can also come in with movement disorders. For example, they might have moya-moya disease with impaired perfusion into the caudate and basal ganglia, resulting in chorea, dystonia as a presentation. It's, I think, more common to see alien hand syndrome, for example, in these parietal strokes, which are often from patent foramen ovale. And then you can have ischemic optic neuropathy, or seventh nerve paresis, Horner syndrome. I saw a patient who came in from Disney World. She had gone to Space Mountain, which, if you've not been there, it's this enclosed space where you get into a roller coaster ride at very high speed and your head thrashes back and forth. And that patient came back and had a Horner syndrome, which she self-diagnosed. She said, "Doctor, my pupil is small." And we worked her up, and sure enough, she had a carotid artery dissection. So that's an unusual manifestation. You don't see that in the 80-year-old. You might see that in the 40-year-old woman. And then isolated symptoms are also common. Headache can be the sole manifestation of stroke in the young. Now, I told you about mechanisms. They are different between young age and old age. We compared this in a paper that was published probably 15 years ago now. If you compare large artery, small vessel, cardiac, and other determined causes, you see that the young patients have a lower rate of cardiac causes, a higher rate of other determined causes such as RCVS, vasculitis, moya-moya, or some other genetic arteriopathy, for example. Now, know if some of this is an artifact of testing. The young patient, we get concerned, we automatically think of less common causes, and we're doing a lot of additional testing beyond the routine cardiac echo and vessel imaging. We do a lumbar puncture, we look for vasculitis, we do PET scans, and so on and so forth. But we rarely do that in an 85-year-old. So I think some of these data are artifactual based upon physician biases and testing biases. But by and large, there is a higher frequency of less common causes of stroke aggregate in the younger population. So there are too many causes to list. So I think it's important to just go over the main causes and then really focus on the approach to diagnosis and management. In my previous talk, I told you about arteriopathies, how they are much more common in the younger population. So I won't touch on the arteriopathy in this lecture. I'm going to focus a little more on the cardiac causes, which are highlighted in the red box. There are many more, but these are the main cardiac causes. I think patent foramen ovale might account for 15% or so of stroke in young adults. And then in your country, I don't know, but in the USA and India, rheumatic valvular heart disease and infectious thrombotic endocarditis, subacute bacterial endocarditis, is very common in the young. Atrial fibrillation is distinctly uncommon. And then cardiac tumors are also uncommon, but should be considered. And you need advanced cardiac diagnostic testing to really diagnose this. There are many hematological conditions, including leukemias, lymphomas, myeloma, antiphospholipid, and then in patients with patent foramen ovale, a hypercoagulable state, which causes venous clots, becomes important. So we don't test for hypercoagulability unless the patient has a PFO. And if the patient has a PFO, then we do protein C, S, antithrombin 3 levels, and others. The only hypercoagulable state that can cause arterial and venous clots is antiphospholipid antibody. And I think homocysteine is the other one that you should not forget. So a few words about PFO. As you know, this little channel in the upper chambers of the heart between the right and the left atrium is present in 25% of the general population. But when you look at stroke in the young, it's present in 40%. So that increased prevalence suggests that this may be a risk factor. Then we've had echo studies showing a clot traversing, a venous clot from the leg coming up to the right atrium and then traversing directly into the left, and from there to the left ventricle and up to the brain. So that channel becomes important as a risk factor, especially if you have an atrial septal aneurysm, where the wall between the two atria moves from left to right more than 1 centimeter. That becomes an aneurysmal wall. And I think the combination of PFO with aneurysm confers a much higher risk for stroke. So now, for the past 30 years, we've been thinking that maybe we should close off this opening to prevent strokes in young adults. There are many techniques to do this. Many devices have been developed. It was surprising that the first 3 trials, the closure, the PC, and the RESPECT trial, did not find benefit. However, in 2017, the one issue of the New England Journal of Medicine had 3 positive trials, including the GORE, the CLOSE, and the extended follow-up of the previously published RESPECT trial, and all 3 were positive. And I think the take-home message here is that PFO closure does confer benefit. However, remember that the baseline risk for a second stroke across the PFO is rather low, probably less than 2%. So these are all relative reductions of a very low baseline risk. And the fact that the recent trials were positive, unlike the prior ones, informs us that it's the advances in technique, but more importantly, better patient selection. For example, the more recent trials took patients with larger PFOs and the more characteristic stroke pattern, for example, unlike the prior studies. So patient selection is critical. I told you about arteriopathies and other things, how you can, what is the approach? Again, things like what is the type of headache, where is it located? If the patient has had preceding TIA or eye ischemia, that becomes important. The clinical setting in which the stroke occurs is important. You've heard this in the previous talk. I'll be brief over here. Remember that you have to examine the arterial pulses, do a careful skin exam, do a careful peripheral nerve exam, because you might miss, let's say, radial neuropathy caused by disseminated vasculitis or myeloma, for example. And then, of course, do a dilated fundus exam. I send patients for fluorescein angiography because you might find some abnormalities. For example, the call for A1 gene mutation has very specific eye findings that could be revealed. Moyamoya disease as well, you might see some changes in the fundus. After the basic clinical and history taking, you move on to diagnostic testing. Now, this is a nice table from Jose Ferro in Lancet Neurology. You can see that for various conditions, you have very different diagnostic tests. For example, for Fabry's disease, which I mentioned in my previous talk, the alpha-galactosidase A activity is important. For CADASIL, a genetic test for the Notch3 gene mutation is there, but you can also do a skin biopsy. For these conditions which are stroke-like, from mitochondrial disorders, again, you have genetic tests, muscle biopsy, lactate level, for example. So where do you begin? I mean, you can't do every test in every patient, right? So I think you have to have a directed approach where, depending upon whether you're suspecting arteriopathy or cardiac or an infection, you might modify your approach. But there's a big array of tests. I looked at the diagnostic yield. That means when is a test positive when it is done. So you can see that if you send hypercoag panel tests, if you send them in a large population, only a minority will actually have a positive result. And as you know, this can be artificially low for the first few days, so you have to repeat it. So the true positive rate is much lower. Now, this is all testing done because you suspect that the patient might have a need. Let's say you do a cardiac echo because you want to rule out a cardiac cause. You do a CSF only when you suspect it. So with that bias, you can see that the diagnostic yield is quite different. Notice here that angiography is invariably positive because you get a clot with a cutoff or you get an arteriopathy. CT MRI, this patient's also had TIAs. So they were positive in I think 85 or 90%, the rest had TIA, so the scan was negative. Holter studies to look for cardiac arrhythmia, it's only a 1% positive rate. So keep these data in mind when you're ordering the tests. You should only do the test if you have a high pretest probability of a positive result, or you're really keen on ruling out a certain diagnosis. Brain lesion patterns are important in young patients. I told you previously about the string of beads, but here's the external capsule anterior temporal lobe involvement in patients with CADASIL. And then snowball lesions, which I don't have on this slide, for Susac syndrome, for example. Advanced MRI, although it has limitations, is, I think, a useful diagnostic tool. It can't be used in isolation, but if you have, let's say, inflammatory CSF and concordant eccentric or concentric enhancement of the arteries on vessel wall imaging, then I think it's safe to say that you're dealing with vasculitis, and then you can move on to brain biopsy to confirm it. Approach to treatment. Now, these are young patients. Just like the older adult, they are responsive to things like intravenous thrombolysis and mechanical thrombectomy. Although there are no trials looking specifically at the safety and efficacy of IVIA approaches in young patients, secondary analysis of the larger trials and the European SITS-MOST registry data has shown that thrombolysis is safe and probably effective. This is important because in the young patient, you have conditions that are not common in older adults, things like dissection. Now, is thrombolysis safe in dissection? I think from those data, it does appear to be so. It's probably also effective. Mechanical thrombectomy, for example, this might be the only approach in a patient with bacterial endocarditis and an M1 occlusion. In such patients, you can't give IV TPA or tenecteplase, but mechanical thrombectomy, we have shown, is safe and effective. So I think you have to modify the approach, but don't forget that a young patient could have a stroke and offer them an IV thrombolysis. I think there are a number of medical legal issues now in the young population where stroke was missed. And it's not the complication of TPA, but the lack of giving TPA that leads to the lawsuit. So be very careful over there. Now, if the patient responds and the clot lyses and goes away, that's great. But if not, the patient is left with a large stroke, don't forget that we have a tool that can not only prevent death, but also result in good outcome, relatively speaking. This tool is called hemicranectomy. So the simply removing the skull cap and allowing the brain to expand has been shown to be highly efficacious. To put it another way, thrombolysis, you need to treat 7 patients to get a perfect outcome. Now, these are a Rankin score of 0 to 1. But these are patients with a heterogeneous NIH stroke scale upon admission. You give TPA to a stroke scale score of 7 or 27 and anything in between, and 1 and 7 will have a great outcome. For hemicranectomy, these are patients who have severe NIH stroke scale scores. So you expect death or severe disability. However, you need to treat only 4 patients to get a patient with a modified Rankin scale score of 3 or less. And I think to treat 4 to get a reasonable, acceptable outcome is really very, very important. There's no other treatment in the field of medicine that is as powerful as hemicraniectomy to prevent death and avoid significant disability. And then there are some surgical non-interventional options such as stenting, balloon angioplasty that could be offered. It is important in women to avoid estrogen exposure. And in patients who have had a stroke, there's an FDA black box warning against triptans, which are vasoconstrictors, so they should be avoided. And as I said earlier, there are no specific trials, but the general principles of secondary stroke prevention apply to the young. Antiplatelet agents, including aspirin, clopidogrel, ticagrelor, and the list is growing. Statins, ACE inhibitors, and nowadays the GLP-1 inhibitors are also very important, especially in diabetics who are overweight. Anticoagulants, including the newer oral anticoagulants, and then aspirin chronically for dissection. I don't know how long you should continue aspirin after a dissection. We generally give it for about 6 weeks to 12 weeks. If the artery is still not completely healed, then maybe you can continue it. Otherwise, I think it's safe to stop it. And then very specific treatments depending upon the cause. For example, you might have cardiac surgery for myxoma or a big vegetation or immune suppression for vasculitis, treatment of tuberculosis, treatment of cancer. This all can really improve outcomes in the young. An important aspect of treating young patients is that they have a lot of post-stroke sequelae. Anxiety is really important. Even after TIA, patients live with the fear of having a stroke for the next 60, 70 years. So that has to be addressed. You can have central post-stroke pain, cognitive changes, depression, epilepsy, fatigue. Fatigue is really important even after a TIA. I've seen patients who don't do well if they return to work immediately, even though they seem normal. I think the brain needs time to recover. So I often counsel them that go slow, start with 1 or 2 hours of work and then build it up gradually and take some rest in the afternoon. There's nothing wrong with that if you feel tired. As I said, there are sobering data from the Future study from Netherlands. They looked at many years and they found that patients with TI or stroke who were followed up for more than 11 years on average, they had a high risk of death. Look at this. Imagine this, you're 30 years of age, you come in with a TIA. 20 years later, 1 in 4 such patients would have died. I think that I was shocked at seeing these data, and I believe them, however. And the rates of death are slightly higher for ischemic stroke. Now, for all subtypes of stroke, the observed exceeded the expected mortality. And you can see here that there's a high rate of death. Now, I asked the first author, Dr. Ratan Jacobs, what is the cause of death? And I think a lot of this was cancer. So I cannot emphasize further that in the young, 7.5% of strokes reveal an underlying diagnosis of cancer. And about 7.5% of patients with cancer get stroke as a complication. So cancer is an important cause of stroke in the young. And over the long term, cardiovascular disease and cancer are important consequences. So as a field, I think we have to start addressing these long-term complications. Our job is not just to give aspirin and statins and say, go home, you'll get better, but really to start addressing the social and non-medical needs, non-medication needs of such patients. So for the long term, I think my colleague in Boston, Lester Leung, has published a nice paper about the treatment strategies. For example, vocational rehab, cognitive therapy, lethargy can be treated with modafinil, amphetamines, and then treatment of depression, epilepsy, and dystonia, for example, and how frequently these things are encountered. So I think these are the issues. Other patients are looking for resources. So this slide lists the various resources, websites, young stroke support groups, and others that are available even in your region in Eastern Europe. So with that, I will end my talk. I hope you enjoyed it. Thank you very much. Enjoy the rest of this session.
We begin with a lecture by Professor Nathan Bornstein from Israel, Director of the Brain Division at Shachri Zedek Medical Center, Chairman of the Israeli Stroke Society, and a leading expert in stroke prevention, who will discuss the management of asymptomatic carotid stenosis.
Dear colleagues and friends, it is a really great pleasure and honor for me to be here on the occasion of the Kyiv Summer School Summit 2026. This is, again, unfortunately, that we have to do it virtually and not in person. As you may know, for many years, I've been supporting Ukraine and the stroke societies in Ukraine. And as both of our countries are in war zone, this is very unfortunate. And we all hope that the wars will stop soon and will end, and peace will prevail. Ukraine and Israel stand together for many years, and my support is fully with you, and we hope to see you next time, next year, in person, in Kyiv, in a peaceful atmosphere and situation. So my talk today is on asymptomatic carotid artery disease, to intervene or not to intervene. This is a very dear topic to me because I started my stroke career with Professor John Norris, late Professor John Norris, who died a couple of years ago during the COVID. And this talk is dedicated to him. He is a great mentor and a great teacher. So we all know that 15 to 20% of all stroke, cardioembolics or artery-to-artery stroke, basically are due to carotid stenosis, like either the plaque with atheroembolic events or the other way, that flow reduction due to hemodynamic strokes. But about 15 to 20% of all ischemic stroke are due to carotid stenosis. Carotid stenosis could be symptomatic, which is not the topic of today. Today, we are talking about asymptomatic carotid stenosis. And this carotid revascularization for asymptomatic patients was for many years a passionate debate. Yes, no, intervene or not to intervene. There are three options how to deal with carotid stenosis. Either with best medical treatment, control your risk factors, do exercise, control your diets, or intervene either with carotid endarterectomy or with carotid stenting. Let's see what we know up till now and what is the current new data that I will present to you. So these are the two studies that were conducted in the end of last century, in the 90s of the last century. The ACAS, the American Carotid Artery Stenosis Study, and the ACST, which is the European one. As you see here, there was absolute risk reduction over 5 years of about 5%. It's a very small benefit, 1% per year, but with perioperative risk of 3%, which means that however the risks are history, the number needed to treat nowadays for endarterectomy, this are talking about endarterectomy only, is now higher because the risk of medical therapy has declined dramatically during the years. When I was in Toronto during my fellowship, and I did the asymptomatic carotid bruit study, the risk of ipsilateral stroke due to severe carotid stenosis was about 2.5%. Look what happened in 2010 or later for the Oxford population-based study. The risk of ipsilateral stroke annually, it's only 1%. So dramatic risk. So most patients with asymptomatic stenosis are better off with best medical therapy. However, we know that some people think that we should intervene, and it was, as I said, it was a big debate, a very furious debate. So for those who think that we should intervene in case of a severe asymptomatic carotid stenosis, means above 70%, there are two options: either carotid endarterectomy versus stent. So what do we know about this? This is the first study, that's a randomized control study of stent versus surgery for asymptomatic carotid stenosis. It's called the ACT-1 investigators. It was published in 2016. And they showed that there's no big difference between stenting and endarterectomy. Both are actually equally on over this 5 years follow-up. But the major trial that was actually a large one that conducted in the UK and other countries is the ACST2. And this was endarterectomy versus stenting in a very large study run by Alison Holliday from UK. It was published in 2021. This was the second asymptomatic carotid surgery trial, including 3,625 patients, follow-up for 5 years, and in this case, the severe disabling strokes that occurred during procedures was very low, only 1%. And if you look at these are the main results. On the left side, you have the including peri-procedural risk, which was, as I said, about 1%. And the end of 5 years follow-up, there was no much difference between CEA, endarterectomy, and carotid stenting. If you look at excluding the peri-procedural, pro-procedural, this complication rates is again just the same, which means that, as you can see, of these 3,625 patients randomized into endarterectomy versus stenting, the peri-procedural and disabling strokes were only 1%, although the non-disabling were numerically more in the CAS, in the carotid stenting, versus the endarterectomy, but overall, the serious complications are similar, uncommon, after competent stenting and CEA, and the long-term effect of these two carotid artery procedures on fatal and disabling stroke are comparable. And even nowadays, the CAS has improved substantially. And after the statins and DAPT, dual antiplatelet, lowering the peri-procedural risk was much lower. And we have new procedures like the MOMA, which is a flow reversal procedure, or TICA, which is very common nowadays in the United States, direct cervical access to the plaque. So we have done a long way to improve the carotid stenting peri-procedural complication rate, which is nowadays seems to be equal to the carotid carotid endarterectomy. However, those studies that I've shown you now, there are carotid endarterectomy versus carotid stenting. But what about this arm? These two studies have not included the arm of best medical treatment. So the question is not just whether carotid endarterectomy is better or equal to carotid stenting, but what about these two procedures against best medical treatment? These are the main questions that we've been asking for many years. Recently, there were two big studies. One was smaller one, the SPACE-2. It's a German study with only 513 patients. It was published in 2022 in the Lancet Neurology. They compare CA versus CAS versus best medical treatment. In this case, they could not show that the primary endpoints were different between these three arms, which means that best medical treatment was equal to carotid stenting and endarterectomy. But these are very small study. Another study that was published recently in the Lancet Neurology in 2025 was a very interesting study. It was the European Carotid Surgery Trial. In this case, they included only patients with low risk of less than 20% over 5 years, means, and they use a very special scale, it's called CAS, the carotid artery scale, and they compare in this trial the best medical treatment alone versus best medical treatment plus these two procedures, either carotid revascularization by carotid stenting or carotid endarterectomy. And they was using this win ratio of clinical benefit, which is called either there was no difference, I mean equal, or best of carotid endarterectomy is better, or carotid stenting is better. And as you can see here, without going into details, they included symptomatic and asymptomatic, but now we're talking about the asymptomatic part of the study, and there was no difference between best optimal medical treatment, OMT, plus revascularization versus just the procedure itself. As you can see, exactly the one equal. So these are two studies, one with low risk patients, one is very small studies. Here comes the new data, CREST-2. That was what we all been waiting for many years. I was included in this as a national coordinator for Israel, and I'm very proud of it and honored. So what is a CREST-2? CREST-2, we're talking about severe asymptomatic carotid stenosis patients. Their treatments and differences between medical management and CEA and treatment between medical management and CAS, which means that there were two studies in one. One study was best medical treatment versus endarterectomy. The other study was best medical treatment versus carotid stenosis, carotid stenting. The primary endpoint was any stroke or death within 44 days, which means per procedure, or ipsilateral ischemic stroke thereafter up to 4 years. It was a very meticulous conducted study and very well done by Tom Broad and the Mayo Clinic in the United States. It was published in December last year, just a few months ago, in the New England Journal of Medicine, and you can see the reference over here. I'll take you through the results because it's a major study which raised quite several difficult questions. So these are the main results. As I said, two studies in one. So if you look at the stenting part, which is medical treatment alone versus stenting, you can see that the odds ratio is 2.13, means the hazard ratio, the relative risk, and it is statistically significant. P-value was 0.02, which means that stenting was better than best medical treatment. If you look at by about 1.3 versus 0.4. However, if you look at the endarterectomy trial on the right-hand side, with again endarterectomy versus stent versus best medical treatment, no difference. In this case, which means I'll show you immediately, this is stenting was significantly better than the endarterectomy, than the best medical treatment. However, the endarterectomy was not better than best medical treatment, or vice versa. Best medical treatment was not better than the endarterectomy, which for me, it was a big surprise. However, let's see what are let's go and dive into the results. So this is primary endpoint, Kaplan-Meier curve estimates of the primary events rate. As I said, within 44 days, adverse events, or ipsilateral ischemic stroke over 4 years follow-up. As you can see here, the absolute difference, this is now the best medical treatment versus stenting. As you can see here, the absolute risk difference was 3.2%, and the p-value was 0.016, with relative risk of 2.13 in favor of stenting. And if you look at again, this is the endarterectomy part. Again, the absolute difference was much less, 1.6%, and the relative risk is 1.43, crossing the zero line, which means statistically not significant, p-value 0.24. If you look at all the complication rates during the procedure, of course, with the best medical treatment on the left side is 0. However, in the CAS, it was 0.13, and 0.13 versus is similar, but a little bit less in the endarterectomy. If you look at the best medical treatment, whether it was well managed, you can see that the achieved goal of blood pressure with less than 130 versus 80 achieved only in about 60% of the patient. Lowering the LDL below 70 was achieved in about 80% of the patients. If you look at the hemoglobin A1C for diabetes, it was achieved about less than 50%. Reducing BMI, also the same. And which means that the target, all this were not achieved maximum best medical treatment, but it was equal between the two arms, either stent versus best medical treatment or endarterectomy. So the question is now, having said all that, do the result of CREST-2 means that stenting should be widely adopted for asymptomatic carotid stenosis? I'll show you that I have some doubts about this. In my long career of treating asymptomatic patients with carotid stenosis, I adopted the best medical treatment arm or lead. But let's see, after the CREST-2, what should we do? So first of all, the low rate of stroke with stenting reflect careful selection of patients, and also very skillful interventionalists. Those that were selected by cherry picking all the best interventionalists all over in the United States and the other part of the world, like in Israel. Which means, is it generalizable? Is this can be achieved everywhere? I'm not sure. The difference between this best medical treatment and was based only on small number. Had 3 events occurred in the standing group, the whole story was so completely significantly different, which means there is, by chance alone, 3 stroke would have occurred in the standing group, it would have changed the whole results. As I said, medical therapy could be further intensified. Only 60 to 70% of patients achieve systolic blood pressure below 130. Less than 80% had LDL level lower than 70, and only 50% of diabetic patients had hemoglobin A1C with a target range, which means had we have achieved better medical treatment, it could be that the results were different. Again, the question is, if it was your mother, cousin, not your sister-in-law, not your mother-in-law, but someone who is dear to you, is the benefit observed over 4 years' time justified the early increased risk from standing 1.3% of side effects, adverse events, versus 0, of course, in the medical treatment group? I'm not sure about it. The rate of ipsilateral stroke was 0.4 versus 1.7 per person year. That means the treating with stenting, only approximately 1 per year patients will benefit from by avoiding best medical treatment at the price of approximately 1 patient having stroke or dying from the procedures, which means over 5 years period, you do 100 procedures, 95% will go under these procedures with no benefit, or not necessarily, unnecessarily. And finally, 2/3 of the stroke in the BMT groups were non-disabling stroke, which means, again, this is disabling versus non-disabling. It's also a question. Therefore, having said all this list of questions about the results, I think that it's reasonable to advise patients with asymptomatic carotid stenosis to start with intensive, really intensive medical therapy immediately and delay revascularization. Of course, we know that not all our patients are very obedient, and all of them do adhere to the best medical therapy the way that we want it, but we should encourage them to start with this in order, and maybe if not successful, then we can advise them to go for stenting. Again, stenting is not justified and is not recommended for elderly above 75 or 80 because of many more complications that occur in this CREST-2. So, having said all that, first game-changing results from CREST-2, it's a game changer. The question is, do they resolve the controversy conclusively, or further studies are needed? As I mentioned, in my opinion, if you look at the green line that was given to stenting for asymptomatic carotid stenosis based on the results of the CREST-2, there are many questions. First of all, as I said, if you are above 80, there was no benefit. So for the elderly, stenting is not beneficial. If you look at this, the whole study was based not on angiography, but on duplex. And the duplex, if you look at the very severe ones, it was very good for the peak systolic velocity over 342, but not as good for those with less than 342, like 75% stenosis. If you look at the diabetic versus no, again, it was good for non-diabetic, but diabetic was less effective. The same with smokers. So I think that further studies are needed, but it probably will never happen. But rock solid validation may not be feasible in randomized control studies because the too few events occur, and you need thousands of patients to include in this particular subgroup of patients that I've mentioned to you. So we all know for many years that the overall rate of ipsilateral stroke over severe carotid stenosis, asymptomatic, is very low. However, there is a subgroup of patients with higher risk than the average that we try to identify in whom surgery or intervention or stenting might be justified. For patients like higher risk feature, like more than the ECST2 that I've mentioned to you, if the carotid plaque, like ulceration, intraplaque hemorrhage, all the carotid plaque characteristic may be at higher risk in some features. And of course, the technique like CA, anesthesia, and cranial nerve protection may be of benefit. And medical therapy, as I said, if you have an optimal regime, maybe you lower the risk. All these points should be taken into consideration. And one more thing is, I think that most of patients with asymptomatic stenosis are better off with intensive medical therapy. However, as I said, can we identify the few who can benefit from intervention? We've tried during the years very attempts to find this vulnerable plaque, the vulnerable patient, the unstable plaque that are in a higher risk by using all kinds of techniques, emboli detection and plaque characterization, biomarkers, and of course, MRI to show the small microemboli to the brain. Unfortunately, in my opinion, up till now, we could not be sure how to identify and characterize this unstable plaque or vulnerable patient to justify intervention. So based on what I've said, and in spite of the fact that CREST-2 was positive for stenting in patients with asymptomatic carotid stenosis, I don't think that we have the answer for all our patients. And if you ask, is intervention for asymptomatic carotid artery stenosis now a standard of care, and CAS treatment is treatment of choice for everybody? No. First of all, I think that there are also in your particular centers, you have to look at the complication rate of the interventionalist. If it's less than 1%, like it was in the CREST, 1.3% that was in CREST, in many cases is more than that. And then you can see whether your patient is obedience and adhere to best medical treatment, and you can achieve a better best medical treatment. I think in this case, you should go for best medical treatment. So in this, I thank you very much. And it was a pleasure to be here again. Hopefully we'll see each other in person on various occasions, and especially in Kyiv next year for the Stroke Summit 2027. If not, we'll see you again in Budapest for the controversies in neurology. It was just, we came back from Poland, from Krakow, and next year is going to be in beginning of April, Budapest, Hungary, and hopefully we'll see many of you there as well. Thank you so much.
We now continue with part 2 of plenary session 5, which will further address modern approaches to stroke diagnosis and prevention. The next lecture is by Professor Terry Quinn from the United Kingdom, David Cargill Chair of Geriatric Medicine at the University of Glasgow and Honorary Consultant in Stroke and Geriatric Medicine, an expert in frailty and stroke outcomes, who will address frailty and its implications for stroke care and research.
Hello, everyone. Thank you for joining me. My name is Terry Quinn. I'm a stroke physician and an academic from Scotland in the UK. And I'm sending you all my very best wishes from here in the UK. For this conference, I've been asked to speak about the interaction of frailty and stroke. Now, I was asked to speak on this topic at a previous conference for your society, and I've been asked to speak about it again. So either the first talk wasn't very good or people wanted to hear more. I'm not sure, but I'm going to share with you some thoughts around frailty and stroke. My title is Frailty and Stroke, Significance and Assessment. But really what I want to think about is that often in vascular neurology, frailty is seen as a taboo. People don't talk about frailty. They don't want to think about frailty. So I've retitled my session the F word, frailty. Before we get started, it's always useful to have disclosures and conflicts of interest. I have been working in the frailty and stroke field for some time. I've been supported by the government in Scotland to do research on the management and assessment of frailty. I've worked again with Scottish Government to institute frailty screening in every hospital in Scotland. I've also had research grants to look at stroke and to look at stroke in older adults. And I lead an international consortium in frailty and stroke. But something that I'm very aware of and something that I want to challenge is that often the stroke world and the frailty world think that they are separate. My government work around frailty did not include stroke, and my stroke research until recently didn't include frailty. And I think that's a false dichotomy. I think actually frailty and stroke often co-occur together. And I hope that I will be able to convince you of that. And if you are convinced, then please do get in touch with me, because you may be able to be part of some of the international initiatives we have around frailty and stroke. Now, to get us started, here is some context. Here is something that some of you may have seen. I've certainly seen it many times before. It is a rejection letter from the journal Stroke. This was a rejection from when I submitted my first paper looking at the epidemiology of frailty and stroke. And you can see from the comments of the editor, that editor did not think that frailty was an important topic in stroke medicine. You can see the reasons why. And that's a viewpoint that many people working in stroke medicine hold. And they will tell me that they're not interested in frailty for some of these reasons. They only deal with defined conditions. They only deal with things that have an understanding of pathology. They feel they don't see frailty in their practice, or they don't have time for frailty, or they think it's not important. So I want to deal with each of those in turn. And I want to start with the misconception that there is no definition of frailty. So here we have two patients that could have a stroke. They could have the same chronological age, but clearly one of those men has aged better than the other. And the difference is biological age, and we can think of biological age as frailty. The frailty has a number of definitions. Some could argue too many people have tried to define frailty, and I've gave some examples of frailty definitions in the boxes here. The words are different, but they have some key elements that are consistent across all the definitions. And the first key element is that frailty is associated with getting older. But that doesn't mean that older age and frailty are synonymous. Even in populations that we might think of as being the oldest old, people aged over 85, it's still the minority that are living with frailty. So while frailty absolutely increases as people get older, it's not an inevitable part of aging. The other key component in these definitions is something around a system that is under stress and can't cope. Different phrases are used to describe that, but I'll describe it with a cartoon. So in the green, we have an older adult living their life. They're robust, they don't have frailty. They have a condition, an illness. Their function declines, but they make a recovery and they go back to where they were. For the older adult living with frailty, the picture is different. They're already on a functional decline. For the same illness, their response is exaggerated. They become more unwell than you might expect. Their recovery is slower, and they don't make the same recovery as the robust older adult. And after that illness, the trajectory of their functional decline accelerates. We can illustrate that with a specific stroke example. So here we have 3 stroke syndromes in a robust older adult. The TIA causes a very transient change in function. The minor stroke causes a larger change in function, perhaps with a period of dependency, but with rehabilitation, the person makes a good recovery. The major stroke has a longer period of dependency. The person doesn't make a full recovery, but makes some recovery. If we then look at those same syndromes for an older adult living with frailty, you can see that even something we think of as benign, like a TIA in the context of frailty, can cause major disability. The minor stroke is associated with a very prolonged period of rehabilitation, and the major stroke is ultimately a terminal event. Another way to think about this, and this is from the journal Practical Neurology, is this little image. So you have 2 flowers or weeds. In panels A and C, they have the same deficit, in the same way that 2 people could have the same stroke deficit on a CAT scan or an MRI scan. But you know the person in A is more fragile than the person in C. They're more likely to not do well as a result of that deficit. So if I've convinced you there is a definition, is there a pathology underlying frailty? Well, there are certainly theories underlying frailty, and I'll explain some of the more common theories. The first is a theory proposed by this gentleman, Ken Rockwood from Nova Scotia, and he said frailty is a cumulative burden. Over the course of your life, the more things that go wrong, the more likely it is when you have your next illness, the system will fail. And he said you can quantify that and create a frailty index. So let me illustrate that concept by raiding my kid's toy cupboard. The Jenga tower is an older adult who is robust. The toy bus is a stroke. And you can see when the stroke happens, the tower wobbles, but it doesn't collapse. It's able to withstand and recover from the stroke. If we think about the cumulative burden of illness theory of frailty, each illness that a person has over their life is like removing a block from the Jenga tower. And as each block is removed, the tower becomes less stable. So we can see here some conditions, each one removing a block from the tower. And now when the same stroke comes, the system collapses. And that's the definition of frailty. And in clinical practice, we often see people who have many, many conditions that have occurred over the life course, so that their tower really looks very unsteady, even with no illness. In those states of advanced frailty, even relatively minor insults, like a TIA, can cause complete system collapse. And you can see in the context of stroke, we have a vicious circle. With frailty, the number and the severity of stroke risk factors is increased, so that when the person has a stroke, that stroke is more severe. They have less of a response to treatment. They have more complications and a poorer recovery, and that in turn leads to more stroke risk factors. Now, in all of this, I've been thinking about the negative things, the things that put people at risk. The flip side of that, in an area where I'm increasingly interested, is resilience, because we recognize there are also older adults who do incredibly well. And the things that seem to be associated with resilience are on the slide. Things like early life education, a good social network, socioeconomic advantage. Another theory of frailty was proposed by this lady, Mary Freed. She said we're all clinicians and frailty can be assessed clinically. Frailty has an end of the bed phenotype. And that phenotype is illustrated here. It consists of unintentional weight loss, exhaustion, weakness, sedentary behavior, and slowness. And you can quantify all of these things as illustrated in the slide. A final theory of frailty is from the gentleman at the bottom of the slide. That's Bernard Isaacs. Professor Isaacs had the job that I now hold of Professor of Geriatric Medicine. And he recognized that in an older adult living with frailty, when they become unwell, they respond to that illness in a stereotyped way. They don't follow the classical textbook presentation. Rather, they respond with what he called the geriatric giants. And what are those geriatric giants? Well, Bernard Isaac proposed that when any older adult with frailty becomes unwell, whether that's from pneumonia or a head injury or a stroke, they may fall, they may become confused, they may become incontinent, or they may take to their bed and become immobile. To that list, people have added two other geriatric giants. When people with frailty become unwell, they're more likely to suffer from iatrogenesis, medical-related harm, and they're also more likely to suffer from isolation. And those original geriatric giants are incredibly common in stroke. Falls seen in about 40% of stroke survivors. Dementia in about 1 in 5. Delirium about 1 in 4 people with acute stroke. You can see the numbers on the slide. Other people have said to me, well, there is a theory of frailty, but frailty is not something that they see in their practice. So how common is frailty? Well as stroke, I still do general internal medicine. I'm on call today for my hospital, and on my general medical ward, there weren't many teenagers. Modern medicine is the medicine of older age. Here's a typical general medical ward that I would see in the UK. So what about frailty and stroke? Well, we did a systematic review and meta-analysis looking at how common frailty was in acute stroke. You can see there were studies from across the globe, and frailty was common. There is also a condition of pre-frailty where someone is at risk of frailty, and a condition like a stroke could be enough to tip them into the frailty state. and pre-frailty was even more common. We performed a meta-analysis, and the summary was, in acute stroke, 1 in 4 people presenting was already living with frailty. So this is not a niche issue. Now, you may say 1 in 4 seems far too many. There can't possibly be 25% of people presenting with stroke already have frailty. But actually, when you look at other parts of the hospital, frailty is just as common. So in a general hospital, you might find that almost 1 in 2 people have frailty. In the community, people aged over 65, about 1 in 10 have frailty. In care homes and residential homes, 1 in 2 people have frailty. So 1 in 4 having frailty on an acute stroke unit perhaps isn't implausible. Now, when you looked at that table, you will have noticed that there was a lot of variation in the estimates of frailty prevalence. And that's partly due to variations in how the frailty was assessed. Some used the Rockwood approach, some used the Mary Fried phenotype approach, some used other approaches. We instituted frailty screening in the stroke unit that I work in North Glasgow. We used a frailty index approach, and we found numbers that generally agreed with the numbers we saw in the systematic review and meta-analysis. About 28% of people coming to our stroke unit had frailty before their stroke, and another 1 in 2 were pre-frail, meaning that overall around 79% of people coming to the stroke unit either had frailty or were at risk of frailty. We also looked at frailty using the phenotype approach, and we found the same numbers, 28% of people with frailty. So if I've convinced you frailty is common, can I convince you that you have the time to look for it? I think one reason why people in vascular neurology don't want to look for frailty is because it doesn't involve neuroimaging. It doesn't involve the neurological examination. What we're not looking for is a research level detailed phenotyping of frailty. Rather, what we're looking for in stroke practice is screening. And screening is possible, but it does come with some challenges. So here we have a lady in the neurointensive care who's had a major stroke. At the time she's in the ICU, clearly she will have a weak grip. She won't be walking. She will be inactive. She'll be feeling exhausted. She'll have weight loss. But that doesn't necessarily mean that she's frail, because all of those things are a result of the stroke and are potentially modifiable. When we're assessing for frailty in acute stroke, we're really assessing for how the person was before the stroke event. And that's not always easy. When we tried to look at frailty phenotype in our stroke unit, we were only able to get reliable information in about half of the people that came to the unit. So what we need are easier methods to assess frailty. And this is the method that we're increasingly using here in the UK. This is the clinical frailty scale. It's an ordinal hierarchical scale that quantifies frailty from 1 through to 9, showing the spectrum of frailty from being very fit to being severely frail and near end of life. Even if that is too complicated, in Scotland we instituted another screening tool that we called FRAIL because of the acronym. And it looked for things like functional problems, whether someone was resident in a care home, altered mental status, instability, and the need for daily support. And we found that that's worked very well in identifying those people who might benefit from input from a geriatrician. In vascular neurology, we perform a lot of scans. Those scans are used to look at the brain and the vasculature, but we can sometimes derive other things. Sarcopenia is a syndrome of age-related loss of muscle mass and function. We found that looking at CT angiograms performed routinely in stroke we were able to derive a sarcopenia index, and that sarcopenia index was actually very good at identifying people who were frail. Now, some people say to me that they don't need to assess frailty because they assess for the pre-stroke modified Rankin scale. Now, we're all aware of the modified Rankin scale. Dr. John Rankin came from Glasgow, my city. And the modified Rankin scale was designed to look at outcomes after a stroke. But it is often used to look at how someone was before their stroke. That's a good idea in theory. But if you look at the wording of the modified Rankin scale, it really doesn't work well for looking at how someone was before their stroke. And my group and many other groups have shown that there's huge inter-observer variability in the modified Rankin scale when it's used before a stroke. So much so, it's probably not a valid assessment. So if you're convinced that screening for frailty is possible, why should you do it? Why is it important? Well, this is perhaps one of the most important slides I'll show in my talk. These are data that show outcomes stratified by frailty level using that clinical frailty score. Looking at length of stay, readmission, and death during the inpatient stay. And you can see that when someone is at the more severe level of frailty, a clinical frailty score of 7 or 8 or 9, their outcomes are terrible. Their outcomes are certainly much worse than someone living with metastatic cancer. And here in the UK, the current thinking is that if you identify someone living with advanced frailty, your whole mindset should change. You're perhaps no longer thinking about curative treatments, and you're more thinking about symptom management and palliation. Specific to stroke, we've shown the practical importance of frailty. This is work from one of my collaborators, Nick Evans. He's based in Cambridge in the UK. And he showed that with increasing levels of frailty, common stroke treatments work less well. So, for example, he found that intravenous thrombolysis worked less well as people became more frail with their stroke. For mechanical thrombectomy, there also seems to be a relationship between frailty and outcomes. These are data from Belfast in Northern Ireland, one of the high volume thrombectomy centres in the UK. And you can see that frailty, more than anything else, was the most important predictor of outcomes. People have argued that frailty predicts outcomes because of ageism. When clinicians see frailty, they no longer act with urgency, or they may not give the best quality care. But that's not what we found in this study. Metrics like door-to imaging time or recanalization were the same for people with and without frailty. The difference was the frailty itself. The effect of frailty can even be seen in TIA and minor stroke. These are data from a large stroke centre in England, and it shows that people living with frailty do less well following TIA and minor stroke when seen in an outpatient setting. They haven't even made it to the hospital. The final argument that I hear, and the final argument that I want to challenge, is that there's no point thinking about frailty because frailty can't be treated. It's true there is no tablet that prevents frailty or treats frailty, but there is a treatment, and the treatment is comprehensive geriatric assessment, as outlined in this diagram here. Comprehensive geriatric assessment isn't just assessment, it's a goal-directed, personalised intervention delivered by a multidisciplinary team that considers the physical, the mental health, function, and history in the context of support and the home environment. And there have been many, many studies that show that comprehensive geriatric assessment works. When I say it works, it doesn't prevent death. Rather, it prevents functional decline, and it allows people to return home. And if you ask older adults what's important to them, returning home and not going to a care home is actually much more important to them than staying alive with disability. So if we have a treatment for frailty and stroke, you would think that guidelines would recommend that treatment. In the UK, we have a guidance document that talks about frailty management in various acute settings, like cardiology or oncology. However, stroke is not mentioned in that guidance at all, and I can say that with some confidence because I helped write the guidance. And it perhaps comes back to the point I made before, that there is a danger that stroke and frailty are seen as separate, when hopefully I've convinced you that really they often occur together. Comprehensive geriatric assessment isn't available to everyone immediately. So we did some work here in Scotland to look at a bundle, a list of things that can be done whenever you identify frailty, and that can be delivered by anyone, not just someone working in a specialist older adult team. The method for creating the bundle was standard and it's outlined here, but perhaps more important are the components of the bundle. And there's nothing here that's complicated. A lot of frailty care is about doing the simple things, but doing them consistently and doing them well. So in the bundle were interventions like medication review, assessing mobility, assessing continence. Now, if some of that bundle looks familiar, it's because it looks very similar to the components that have been prone to be the effective parts of an acute stroke unit. And again, I come to my argument that frailty and stroke and dementia are actually more similar than they are different. If we are giving really good acute stroke unit stroke care, it may well be that by default we're also giving good frailty care. But my concern is, here in the UK, care is becoming more fragmented. And rather than offering holistic care, we're offering discipline-focused care. Here we have an older lady with stroke who has a delirium. And what I don't want to see is a situation where a stroke specialist only looks after the stroke, a frailty specialist only looks after the frailty, and a delirium specialist only looks after the delirium. I don't think that's in that patient's best interest. With the advent of advanced imaging, changing the boundaries around mechanical thrombectomy, acute stroke care is becoming much more technological and much more interventional, and that is great. That is life-saving and life-changing for many, many people. But as we make those technological advances, we have to not forget the basics. Basic nursing care, basic medical care, because those are the things that are going to help those people living with frailty who make up such a large proportion of our stroke care and of our stroke patients. So, hopefully I have convinced you that there is a definition of frailty. There are theories of frailty. Frailty is common in stroke, and it doesn't take a lot of time or effort to screen for frailty. Frailty is associated with poor outcomes following stroke, but there are things that we can do about it. Thank you very much for listening. My contact details are on the slide, and if you are interested in frailty and stroke, please do get in touch with me. Thank you, and enjoy the rest of the conference.
We will close the program with a lecture by Professor Michael Odell from the United States, Professor Emeritus of Clinical Rehabilitation Medicine at Weill Cornell Medicine and an internationally recognized expert in neurological rehabilitation and stroke recovery, who will present on current approaches to stroke rehabilitation and motor recovery.
Hello, my name is Dr. Michael Odell. I'm Emeritus Professor at Weill Cornell Medicine, the Department of Rehabilitation and Medicine. I'd like to thank Professor Floman and the organizing committee for the invitation to speak today. My topic is stroke rehabilitation and motor recovery. The outline today will be a discussion of motor recovery versus functional recovery, a bit on passive and active recovery mechanisms, exercise in motor recovery, enhancement strategies, and conclusions. Before I start today, I wanted to just briefly talk about the International Classification of Functions because I will be using some of this terminology. So just briefly, disease is what goes wrong with human beings at the level of the cell. Impairment at the level of the organ and tissue. This is commonly called signs and symptoms. Activity limitation at the level of the person. This is function. I tend to use performance more than I do function. And finally, participation deficit, things that go wrong at the level of the society. It's really important to distinguish two terms when we talk about stroke rehabilitation: motor recovery versus functional recovery. When we talk about motor recovery, we talk about improvements in things like strength, in the speed of an arm and a leg, in the accuracy. We're talking about fewer impairments. Motor recovery can result from a couple of processes. One is natural recovery. These are the improvements that occur passively. Doesn't matter what we do, it's the natural recovery process. The second area is rehabilitation interventions. This is an active process. It requires participation. It requires exercise on the part of the patient. Functional recovery is something quite different. This is an improvement in actual performance. We usually talk about things like activities of daily living, instrumental activities of daily living, mobility, communication, things like this. This is fewer activity or performance deficits or limitations. Functional recovery can for sure occur as a result of improvements in motor recovery, improvements in impairments, both passive and active. But importantly, functional recovery can also occur as a result of compensatory strategies. For example, using the unaffected parts of the body after stroke, the use of devices, the use of equipment, or changes in the environment. Functional recovery is very complex to measure. If we look at performance, it may look the same regardless of where we're looking at compensatory strategies or motor recovery. It's very difficult to differentiate. So when we use motor recovery and functional recovery, we mean very different things, and it's important to differentiate between those two. I want to talk briefly about the mechanisms of motor recovery, focusing mostly on active processes. Passive processes are things like the reduction in local edema surrounding the penundrum and the infarction, resolution of diaskesis. These are areas distant to the area of ischemia that have decreased blood flow that resolve over time, and changes in the concentrations of various factors near the area of ischemia, such as neurotransmitters, ions, particularly potassium, and other things. These are passive processes. These occur no matter what we do and improve with time. This is opposed to active motor recovery processes. This requires participation in rehabilitation, and that always means exercise. Let's discuss just a few of the mechanisms for active motor recovery in rehabilitation. The first is optimizing the remaining cortex, the part of the cerebral cortex that is not damaged by the stroke. One of the mechanisms is to optimize the remaining cortex. This can occur by the opposite side of the brain picking up functions or picking up the slack for the damaged part of the brain. This is called equipotentiality. This can also occur by areas surrounding the area of ischemia near the damaged areas, picking up the functions that have been damaged. Now, this has to occur as a process of exercise and pushing that part of the brain to reorganize. This is work that was done several decades ago by Randy Nudo, looking at primate research. This is because this is a result of active rehabilitation, active exercise. It's important to realize that you cannot do rehabilitation in stroke to someone. You have to do it with someone, emphasizing that participation is absolutely essential. The second mechanism is synaptic plasticity. This is the concept that when a neuron is fired, so to speak, there is a long-term either stimulation or depression of that neuron that leads to a longer than expected stimulation of the postsynaptic neuron. This can occur as a result of repetitive exercise. It can also occur as a result of a medication or a drug, and also occur as a result of various neuromodulation strategies that we're going to talk about a little bit later. Repeated stimulation actually causes more receptors, more postsynaptic neurons to be stimulated, and with time, there is less threshold for stimulation for those neurons. In other words, it gets easier to stimulate those neurons and they happen more quickly. This is called Hebbian plasticity. It's a very active process, but for this to occur, it requires exercise. Axonal sprouting is a process that occurs ipsilaterally in small and medium strokes and probably contralaterally in larger strokes. This occurs in the peri-infarction zone, usually within about a month or so. It can occur locally or at longer distances. And finally, latent tracks. Much like an airliner or an airplane, the brain has multiple tracks that go from one place to another, many of which are latent or unused unless a damaged part of the brain occurs. It's been said, where there's a wire, there's a way. This is part of the reason that when after a stroke, if there is on functional MRI, both sides of the brain are activated. This reflects an unsuccessful recovery because it represents the brain unsuccessfully trying multiple pathways to reconnect. Using my very fancy artwork, this is a representation of the latent tracks. Assuming that before a stroke, the yellow track is the track that is being used, and the blue, green, and red tracks are latent. In other words, they could work, but they are not being used. After a stroke, let's assume that the yellow, blue, and green tracks are damaged. With exercise, the brain reroutes the information to the red track that is undamaged, and information gets from point A to point B. The other way that this can occur is through nodes of connectivity. This concept of connectivity is very, very important in stroke recovery. The information is bounced around among multiple nodes until a pathway is found from point A to point B, and recovery is achieved. This is very, very complicated, I realize, but I just wanted to reemphasize very quickly that the natural recovery or passive motor recovery occurs here at the level of the tissue, but requires no effort on the part of the patient. That motor recovery, the active recovery, also occurs here at the level of the tissue, but it requires rehabilitation, active exercise on the part of the patient. Functional recovery requires certainly can occur as a result of motor recovery, but also can occur using compensatory mechanisms, either altering the environment or altering the individual. And so can encompass several of these strategies. I wanted to mention the 6 categories that we use for intervention and rehabilitation medicine. Rehab and stroke rehab is all about managing symptoms. We prevent secondary disability. It's much better to prevent a disability than treat a disability that has already occurred. We enhance the affected systems. This is essentially motor recovery, using exercise to treat motor recovery. We can also enhance the unaffected systems, modify the environment, or modify the person with various bracing. These are all examples of compensatory strategies. And so importantly, we can maximize participation. This means keeping the patient medically stable. It means minimizing any pain that might prevent the patient from participating in therapy, and addressing any cognitive issues or mood or motivation issues that might prevent the patient from maximally participating in therapy. Again, motor recovery is someone actually gets better. There's an increase in muscle strength, muscle control. Functional recovery is someone who does stuff better. There's an increase in performance that may be a result of either motor recovery or the use of compensatory strategies. So let's talk a little bit about strategies to enhance motor recovery following stroke. Before that, it's probably pertinent to talk a little bit about exercise approaches in stroke in general. Whether the upper extremity or the lower extremity, few patients following stroke have an absolutely full recovery. There's still a lot of knowledge gaps that we have, but there are a few things that we do know. Let me just review a few of those things in terms of what we know about exercise following stroke. 1, from the AVERT trials, we know that it is advisable not to start exercise less than 24 hours following a stroke. We know from the AVERT trial that if this is done, the outcomes are actually worse than if exercise is started after 24 hours. The VECTORS trial was conducted during inpatient rehabilitation, looking at various intensities of exercise. We know from that trial that more is not always better. The group that was randomized to receive a more intensive degree of exercise actually did worse than the groups that were randomized to a less intensive exercise regimen during inpatient rehab. The recently published CPAS study showed us that the timing of exercise after stroke does matter. This is a study where during the first year after stroke, patients were randomized to early, mid, and later additional 20 sessions of exercise. And it showed that actually those that were randomized a few months to exercise a few months after stroke did better than those who were randomized earlier or later. The EXCITE trial is a very famous and very often cited trial. This is the use of constraint-induced motor therapy, where the so-called good extremity is restrained and the weak extremity following stroke is forced to be used many hours a day for a 2-week period of time. There's no question that constraint-induced motor therapy works and that it lasts even up to 2 years following the treatment. Unfortunately, it's not used very often because it's quite intensive, it's expensive to implement, and quite frustrating on the part of the patient. So even though it works, it is not implemented very often. The iCare study looked at the use of 30 hours of upper extremity therapy exercise over a 10-week period, but showed that even in that intensive therapy, it was no better than standard of care. But when that therapy is increased in intensity over a shorter period of time, this is the Queen Square program, 90 hours over 3 weeks. These are folks that are about 3 to 4 months following stroke. There were significant gains in both the impairment and activity, both in terms of the gains in strength as well as the gains in performance. And it suggested that if those exercise programs were started earlier and at a higher level, that performance was improved. And finally, within the setting of inpatient rehab units, recent data has suggested specifically for gait programs that increasing the intensity of walking programs by about a third led to better gait outcomes, not only at discharge from inpatient rehab, but also at a year following discharge. A couple of variations on exercise recently have also suggested improvements. Mirror therapy, where mirrors are set up to essentially trick the brain into thinking that the weak extremity is moving, have been quite promising. Recent Cochrane reviews have shown that there is a moderate quality of evidence showing a significant effect on both motor improvement as well as performance. In addition, virtual reality strategies have shown improvements over conventional therapy. This includes a Cochrane review published just last year that concludes there's at least slight improvement using virtual reality. Kramer and Associates at UCLA also found that telerehabilitation was at least as good as in-person therapy in looking at upper extremity recover. This is very important from a cost standpoint and an access standpoint. This was replicated last year, looking at both performance and for upper extremity and balance for lower extremity. As a whole, the data suggests that we really grossly underdose exercise therapy following stroke, both in terms of inpatient and outpatient therapy. It's a very difficult phenomenon. Therapy takes a lot of time. It's expensive to provide. In many parts of the world, the therapists that provide that care are in short supply. And it's difficult to do. Whatever the approach, it's very clear that the crucial component in this therapy after stroke is active exercise on the part of the patient. So how do we increase or augment the effectiveness of this exercise for what we're able to provide? Very important question. Before we address that, though, I just wanted to point out this really excellent article by Mayer, published in 2019. It points out 15 principles of neurorehabilitation exercise based on motor learning and plasticity. As we look through the literature, of these 15 principles, 2 appear to be most cited. 1, task-specific activity. If you want a hand to improve after stroke, then the exercise needs to be at the hand, not the elbow, not the shoulder, the hand. The second is repetition or mass practice. It takes many, many, many repetitions for that improvement to occur. Now, there are other factors that appear to be important as well. Variability, both within a session and over time, sensory stimulation, as well as the motor exercise progressive, increasing the difficulty of the exercise, explicit feedback. Those are important, but task-specific activity and mass practice appear to be the most important. I also want us to consider the absolute importance of the personal interaction between the therapist and the patient as well. I think this is a really underestimated aspect of rehabilitation. A great therapist is so valuable to the rehabilitation process, and it's really impossible to quantify. It's the secret ingredient of stroke rehabilitation. And again, participation. If the patient doesn't participate in the stroke rehabilitation, in the exercise, they will not get better. So, what are some strategies to augment exercise? We're going to talk about these just briefly and talk a little bit about the literature supporting them. Everybody wants a magic pill to make somebody better. The theory behind pharmacologic approaches is that either medications will prime the pump to make exercise more effective, or that medications will actually make a patient behaviorally participate better in the exercise. Unfortunately, we really have not found the magic bullet in this case. Early L-DOPA studies that seem to be effective have not been replicated, including just the estrol levodopa study that was published last year in JAMA. Seemed to be no effect whatsoever. Dimazepril studies are small. Their results are mixed. Initial excitement over the FLAME trial looking at fluoxetine just completely dispelled in larger studies looking at SSRIs. GABA agonists failed. There really are no well-designed clinical randomized clinical controlled trials in stroke that indicate there are medications that improve the exercise efficacy following stroke, unfortunately. Robotics have been around for a good 20 years, both upper and lower extremity. The theory is that the use of robotics grossly increase the number of repetitions that can be achieved, are enjoyable because they use games, and include the sensory or haptic feedback during exercise. They can be expensive and take up a lot of space. To their advantage, many of these machines can actually collect kinematic data that can be very helpful in the planning a rehab program. The best study for robotics is the Ratul study done in Great Britain a few years ago. They used upper extremity robots. The regimen was dose matched to usual care and showed no difference in outcome measures. That was replicated in 2 studies shortly after that from France. There may be some advantage to lower extremity robotics in severe stroke, but that is about the extent of the evidence base. But despite the underwhelming clinical data, at least in the United States, robotics programs are widely available, primarily in outpatient settings at rehabilitation centers. Functional electrical stimulation is the stimulation of intact peripheral muscle. The systems widely vary depending on where the stimulation occurs. There is some evidence of improved motor recovery, so-called therapeutic effect, but it's also, these devices are also used to improve gait in the lower extremity as well. This is called the orthotic effect. When used to improve gait, there appears to be a decreased physiologic cost of walking, but gait speed appears not to be changed at all. There is a moderate degree of evidence that FES decreases, that improves performance, probably more so in the upper extremity than the lower extremity. Neuromodulation is a strategy that a device actually alters cortical activity in the brain. And there are different approaches to this: inhibitory, excitatory, invasive, non-invasive. Probably the most famous of this is the recently published VNS rehab trial that we were part of at Cornell. This is a surgically implanted device that stimulates the vagus nerve implanted here at the base of the neck. This was a randomized controlled trial that showed that over a 6-week period, stimulation did improve minimally clinically important difference on both the Fugl-Meyer and Wolf motor function tests. These improvements appear to have maintained for 1 year following treatment. Recent meta-analyses, including this VNS rehab trial, showed that it is effective for upper extremity motor recovery. There are actually now surface stimulation trials that appear to be somewhat effective. The Everest trial was a invasive epidurally placed cortical implanted electrodes that was published several years ago that did not appear to show significant improvements over baseline. Neuromodulation also includes transcortical magnetic stimulation. This is a non-invasive strategy used primarily for the arms because, as you can see, when you look at the homunculus, the arms are much more accessible on the surface of the brain than the legs that are buried more medially and deeper. Meta-analyses show that increased grip and in motor recovery can occur. This meta-analysis did not include what's probably the best study of TMS, which was the niche study that showed no difference, unfortunately, between sham and active treatment in Fugl-Meyer assessment or any of the secondary outcomes. A systematic review in 2021 did show that there was some upper extremity improvement in impairment, in other words, strength, as a result of TMS. However, the data is somewhat mixed. Transcranial direct current stimulation is somewhat safer and easier to apply than TMS. Small current is applied through the scalp to alter the excitability of the cortex, as opposed to TMS, which is used to prime the pump, so to speak, before exercise. TDCS is used during exercise. Recent meta-analysis showed moderate evidence for increased performance, but not so much impairment in strength, neglect, and cognition. Again, evidence seems to be stronger for performance rather than the impairment level. And finally, there are miscellaneous strategies that are under active experimentation at the moment. Several stem cell strategies are being tested, both IV, intraarterially, and actually even intracranially placed cells. The safety seems to be pretty good at this point, with a decent suggestion of efficacy. Interestingly enough, these are trials that don't include exercise generally. There are neuropeptides that are under consideration, growth factors, monoclonal antibodies, and brain-computer interfaces. This is work that is particularly pertinent in their study at the University of Pittsburgh. So there are many strategies that are coming down the road that will be interesting to see what develops over the next few years. So in summary, it's essential to distinguish between motor recovery when somebody gets better as opposed to functional recovery when somebody does better. Remember, this may be a result of compensation as well as motor recovery. There are a variety of mechanisms, passive and active recovery. Active recovery must be as a result of exercise, and to exercise, the patient must participate. This means they have to be medically stable, they need to be pain-free and non-depressed enough to participate in the exercise regimen. There's good evidence for constraint-induced motor therapy and massive practice exercise, but it's tough to implement. There's encouraging data for mere therapy and virtual reality as a modification to exercise. There's decent evidence for vagus nerve stimulation, transcranial direct current stimulation, and early data for some of the earlier experimental therapies. Results are mixed for FES, TMS, and robotics. And unfortunately, there are really little evidence supporting a pharmacologic strategy to enhance motor recovery following a stroke. I thank you for your attention. If there's any questions that anybody has or further commentary, please feel free to reach out to me at my email, mio2005@med.cornell.edu. Thank you very much for your attention today.
Dear colleagues, dear friends, as we come to the close of the Kyiv Summer Stroke Summit 2026, I would like to thank each of you, not only for your participation, but also for your commitment to improving stroke care. We are deeply grateful to our outstanding faculty. Your expertise, your intellectual honesty, and your willingness to share not only successes, but also uncertainties and limitations have made this meeting truly meaningful. Bringing together leading experts from Europe, North America, and Australia is not just a matter of prestige, it is a responsibility to translate knowledge into better care. I would also like to thank all participants. Your engagement makes it clear that this is not just another conference. It is a community of clinicians who are not satisfied with the status quo and are ready to make a difference. Over the past 3 days, we have seen both the strengths and uncomfortable gaps of modern stroke medicine. Despite real progress, the reality remains blunt. Too many patients in Europe still do not receive evidence-based care. Too many are not treated in stroke units. Too many lives are lost or prematurely changed, not because we lack knowledge, but because systems fail to deliver what we already know. The updated stroke action plan for Europe is not simply a strategic document, it is a call for accountability. It clearly states that improving outcomes is no longer a question of what to do, but rather a question whether we are willing to implement it. If there is one message to take home from this summit, it is this: knowledge alone does not save patients. Systems do. Decisions do. Implementation does. We believe that Kyiv Summer Stroke Summit has become more than a meeting. It has become a platform for change. Meeting that should not be missed, meeting that connects science with practice and discussions with responsibility. We'll carefully review your feedback and evaluation forms, not as a formality, but as a tool to make the next summit sharper, more practical, and more impactful. We would also like to warmly invite our colleagues from other countries to collaborate with us in shaping the program of the future summits. The challenges of stroke care are shared across borders, and so must be the solutions. Thank you for your trust, for your time, and your commitment. Let us turn knowledge into action. We look forward to seeing all of you again.